Good morning. Thank you all for being here today. The subcommittee will come to order. Before we begin, I want to ask unanimous consent for our colleague from Maryland, Dr. Andy Harris, to sit at the dais and participate in today's hearing without objection, so ordered. We have Mr. Miller here this morning as well, the chairman of the full committee. I'm happy to see. Thank you for being here, Mr. Chairman. With that, I'd like to welcome you all to today's hearing, Between Peril and Promise, Facing the Dangers of VA's Skyrocketing Use of Prescription Painkillers to Treat Veterans. Today's subject is one of the most serious and significant we will discuss all year, and it's one that's particularly poignant and personal to me. I've spent 20 years serving our veterans as a physician at the Oscar G. Johnson VA Medical Center in Iron Mountain, Michigan. In that capacity, I understand all too well what it means for a veteran and a patient to be in pain. Pain can be an unrelenting enemy, one that thwarts an individual's ability to work and enjoy the activities they once loved, hinders their relationship with their family and friends, and impacts their capacity to be comfortable in their own home. On a daily basis, my veteran patients would confide in me about the pain they were in many ways in which they were hurting, and more than anything else, their desperate desire to find relief. Perhaps nowhere else is that more clear than in the heartbreaking testimony that we will hear shortly from two surviving spouses, Heather McDonald and Kimberly Green. Their husbands, Scott McDonald and Ricky Green, honorably served our nation in uniform and came home, as far too many of our returning veterans have, hurting and in pain. These men sought treatment from the department charged with caring for them, the VA, hoping to get the help they needed so they could once again take full and successful ownerships of their lives, without pain as their constant companion. Sadly, rather than getting the best of care anywhere, Scott and Ricky were prescribed a disturbing array of pain, psychiatric, and sleeping medications without any clear consideration or special attention paid to how these powerful drugs were interacting with each other or affecting Scott and Ricky's physical and mental well-being. The combined effects of these multiple medications ultimately took their lives. We will also hear from two veterans, Joshua Rensler and Justin Minyard, who will give us a first-hand account of the struggles they faced with VA's apparent over-reliance on opioid-based medications for pain management. At one time, Joshua was prescribed 13 different medications. Despite his pleas that the medications weren't working, he was never referred to a pain specialist. Justin was prescribed enough opiate pain medications on a daily basis to treat 4 terminally ill cancer patients. He eventually sought care outside of VA to find an effective treatment to manage his pain. To say that I am disturbed by these accounts and by the multiple reports we hear every day about the skyrocketing use of prescription painkillers, particularly opiates, to treat veterans in pain would be a major understatement. VA's Band-Aid approach to suppressing the symptoms of pain rather than treating the root cause must stop. VA maintains a pain management treatment model that makes primary care, rather than specialty care, the predominant treatment setting for veterans suffering from pain. Yet, as I know from personal experience, the multifaceted nature of chronic pain, particularly when multiple medications are being prescribed, should not be managed by a primary care physician, but rather by a qualified pain specialist who is trained to understand the complexities of treating these conditions. I want to be very clear that this hearing is not intended to vilify the many hardworking primary care providers working every day to care for patients in pain at VA facilities across the nation. I've been in their shoes. I know the challenges they face in providing the high-quality care our veterans deserve. Rather, our intent here today is to initiate better provider practices and, most importantly, better care coordination for our veterans and their loved ones so that no other family has to experience the pain, the suffering, or the loss that our witnesses on the first panel have already experienced. It is critical for VA to take responsibility for its failures and rise to the challenge to change and take immediate action to adopt effective pain management policies, protocols, and practices. We have already lost too many veterans on the home front to battles with chronic pain. The stakes are too high for the VA to continue to get it wrong. This is a really important matter to me. I think that in my own personal practice, I realize that, I just don't know everything there is to know about pain, and that we always send people with chronic pain to a specialist. And to not do that and just appoint a specialist is just inconceivable to me. I will now yield to our ranking member, Julia Brownlee, for any opening statements she may have.
Thank you, Mr. Chair, and good morning. I'd like to thank everyone who is in attendance today for being here. Chronic pain is a debilitating condition that affects veterans at a much higher rate than the civilian population. According to the Department of Veteran Affairs, in the newest cohort of veterans, chronic pain is the most common medical problem reported in veterans returning from the battlefield, with estimates as high as 60% of those who seek treatment in the VA. Modern warfare often leads to serious but survivable physical and neurological injuries such as amputations, spinal cord injury, traumatic brain injury, gunshot wounds, and many more. Oftentimes, these same veterans experience mental health issues as well, such as post-traumatic stress disorder and depression. And while advances in medical technology have saved the lives of many wounded soldiers, many veterans of our armed forces are forced to live a life that is dominated by acute and chronic pain. Providing safe, effective, adequate pain management is a crucial component of improving veterans' health care. The treatment of chronic severe pain often involves physicians prescribing highly addictive painkillers that, if not properly monitored, can lead to death. Testimony from our first panel highlights the dangers of prescription drugs and just how quickly veterans get trapped in a rapid downward spiral of addiction and pain. I know that VA has a national pain management strategy, and I look forward to hearing from Dr. Jesse regarding the ramping up of pain clinics and services throughout the Veterans Health Administration. I am also very interested in progress being made with the Department of Defense on transitioning service members and the management of medications between the agencies. Finally, VA recognizes that chronic and acute pain among our veterans is a serious problem and, in fact, is a priority. I applaud them for taking the lead on this issue, but I am concerned that comprehensive pain care is not consistently provided throughout the VA's healthcare system. I look forward to hearing from our witnesses. I thank you again for being here. It's important for this panel and members and the public to hear your stories. Thank you, Mr. Chairman, and I now yield back.
Thank you, Ms. Brownlee. I'd like to yield to Chairman of the full committee, Mr. Miller from Florida.
Thank you, Dr. Benishek and Ms. Brownlee both for having this very important hearing. And as you've already said, that many of our service members are returning home with serious injuries from the battlefield and very acute pain. And as they transition to veteran status, the pain often lingers and leads to chronic illness. For these veterans, the pain level, it's the pain level, not the veteran, that sets the agenda for the day. It sets the tone for their families, and it keeps the veteran, in many cases, from fully participating in their daily lives and activities that they may once have had. Yet when these veterans reach out and entrust the VA to relieve their pain, the treatment they often receive is the system-wide default of prescribing prescription painkillers. CBS News has recently reported that based on VA data over the past 11 years, the number of patients treated by the VA is up 29%, while the narcotic prescriptions written by VA doctors and nurse practitioners are up 259%. Look, veterans depend upon VA to uphold its mission of restoring the health of those who have borne the battle. But instead of helping them manage their battles with the pain that they experience, VA has opted instead to use a treatment that has the power to destroy rather than to restore their lives. VA can, and it has to change course and act now to reduce their reliance on the use of prescription drugs. The veteran patient and their loved ones must be listened to be followed up with closely and supported with a treatment that can best help them regain happy and healthy lives. Anything less is unacceptable. I yield back.
Thank you, Mr. Chairman. I would like to now formally welcome our first panel to the witness table. As I mentioned earlier, joining us is Heather McDonald from South Vienna, Ohio, and Kimberly Stowe Green from Fort Smith, Arkansas. Mrs. Green is a veteran of the United States Air Force. Thank you, ma'am, for your service, and thank you both for being here to deliver what I know is going to be very difficult testimony for you. Mrs. McDonald and Mrs. Green are joined by Joshua Rentschler from Olympia, Washington, and Justin Minyard of Orlando, Florida. Mr. Rentschler and Mr. Minyard are both veterans of the United States Army and both continue to serve today as advocates for their fellow veterans. Thank you both for your service and for all the hard work that you continue to do. We appreciate you all being here with us today to tell your stories. Mrs. McDonald, please proceed with your testimony. We like to keep it around 5 minutes so that everyone has an opportunity to be heard.
Foremost, I want to thank you all for inviting us here today to speak. This is a cause that I know that we are incredibly passionate about. After graduating from Belpre High School in 1995, Scott Allen McDonald took an oath to uphold the dignity and the honor of the United States Army. For 15 years, he served honorably in the uniform of his country and was proud to serve as a UH-60 Black Hawk mechanic and crew chief for medevac unit. Bosnia, Panama, Iraq, and Afghanistan are only a few of the war-torn countries he dedicated his life to changing. In his career, he experienced heartache, unimaginable violence, death, and the overall devastating effects of war. He saw many of his fellow soldiers give the ultimate sacrifice, narrowly escaping many times himself. He loved his country and what the American flag stands for. He was a brother in arms to thousands of fellow soldiers and a truly remarkable man that never met a stranger. Scott had larger than life expectations for his children. And because of his commitment and honor, in January of 2011, we married. On April 30th of 2011, Scott's career with the Army came full circle, and he hung his uniform up for good. He began seeking the treatment from the VA for back pain and mental illness. The Chalmers P. Wiley Ambulatory Care Center in Columbus, Ohio, immediately started prescribing medications, beginning with ibuprofen, Neurontin, and meloxicam, and graduating to Vicodin, Klonopin, Celexa, Zoloft, Valium, and Percocet. This is where the roller coaster began. My husband was taking up to 15 pills a day within the first 6 months of treatment. Every time Scott came home from an appointment, he had different medications, different dosages, different directions on how to take them. And progressively, over the course of a year and a half of starting his treatment, the medications had changed so many times by adding and changing that Scott became changing. We researched many of the drugs that he was prescribed online and saw the dangerous interactions that they cause. Yet my husband was conditioned to follow orders, and he did so. On September 12th of 2012, Scott attended another of his scheduled appointments. This is when they added Percocet. This was a much different medication than he was used to taking, in which they prescribed him not to exceed 3,000 milligrams of acetaminophen. I'm sorry. Again, my husband followed orders. Approximately 100 hours on the 13th of September, I received home from my job. I found Scott disoriented and very lethargic. I woke him and asked him if he was okay. He told me he was fine and that he just took what the doctors told him to take. At approximately 07:30, I found my husband cold and unresponsive. At 35 years old, this father of two was gone. I ask myself why every day. And when I asked the VA why more tests weren't performed to make sure he was healthy enough, they responded by saying it is not routine to evaluate our soldiers' pain medication distribution. A simple, I'm in pain, constitutes a narcotic, and this isn't working, constitutes their change of medication. I was sickened and disturbed by their response, and I decided at that point no one else should die. I have no doubt that if the proper tests were being performed on our men and women, I would not be here today, because my husband would be. I have no doubt that for thousands of the soldiers that have fallen since coming home from war would be here today. As the silent soldiers and the spouses of our military members, we almost expect the possibility they won't come home from war. But we cannot accept that they fight there for their country, and after the battle is over, they come home and die in front of their children and their loved ones. And this has got to stop. When our men and women signed that contract, they gave their bodies to their country. And I ask now, as the people that have the power and the ability to make these changes happen, to force regulations to change on behalf of all of the veterans out there that have died. And for their families, I beg you to reopen this issue and reevaluate the distribution of narcotics to our men and women when they come home. Because you don't only take the lives of these men and women, but you tarnish the lives of their families forever. They selflessly chose to wear the uniform of the United States military. And when they come home, they should not be treated as numbers, nor should they be labeled as if they're no longer a productive or useful part of society.
Thank you very much, Mr. McDonald. I truly appreciate you being here and testifying. Mrs. Green, would you please begin?
Chairman Pinchuk, Ranking Minority Member Brownlee, and all distinguished members of the subcommittee. My name is Kimberly Green. I am honored to have been invited to speak to you today at this hearing. I am accompanied here today by my attorney, Brant Mittler, who is also a medical doctor. I respectfully request that my written statement be incorporated into the official records of this hearing. I live in Fort Smith, Arkansas. I served my country for 21 years in the United States Air Force, serving both on active duty and reserve status. I retired as a Master Sergeant from the Arkansas Air National Guard and the widow of Ricky Green. My husband served his country for 23 years, serving both on active duty status and in the reserves. He was a military policeman and a paratrooper, and he served with distinction in Desert Storm. He retired as a Sergeant First Class. My husband, Ricky Green, died as a result of the VA's skyrocketing use of prescription painkillers. On behalf of my husband, myself, and our two grieving sons, I want to ask this committee to do all that it can to prevent other veterans from dying in the same manner that my husband died. My husband died on October the 29th, 2011 at the age of 43, 4 days after lower back surgery. The Arkansas State Crime Lab and its medical examiner performed an autopsy and determined that the cause of death was mixed drug intoxication, complicating recent lumbar spine surgery. My husband died because of the prescription pain and sleeping medications that the VA and its doctors prescribed for him and dispensed to him out of the VA pharmacy. In treating Ricky's service-connected back pain, the VA doctors wrote prescriptions for the following drugs: oxycodone, hydrocodone, and the generic versions of Valium, Zoloft, Ambien, Gabapentin, and Tramadol, among others. Ricky trusted the VA doctors and followed their orders. The VA already has written guidelines for prescribing painkillers, but these are not being followed. The clinical practice guidelines, which have been in place since May of 2010, require physicians to closely monitor and evaluate patients who are being prescribed prescription painkillers for chronic pain and warn physicians about the dangers of drug interactions that can cause death. The guidelines also warn physicians to take special care in prescribing pain medications for patients, such as my husband, who had sleep apnea. Unfortunately, again, no such special precautions were taken for Ricky, who got a legal drug cocktail that included oxycodone and diazepam, which were reviewed by the VA and filled by the VA pharmacy on October the 26th, 2011. I strongly believe that my husband was entitled to receive the quality of care that the VA and Department of Defense set forth in their guidelines. However, last year, the VA's National Program Director for Pain Management admitted that VA has not fully implemented the guidelines. I note that statistics show in Fayetteville, Arkansas, where my husband was treated, there is a high incidence of overprescribing pain medications for veterans. In my husband's case, he asked the VA to reduce the opiate pain medications he was taking, but the VA did not listen. I'm proud of my husband. After serving his country for over 20 years in the military, he went back to school and earned his college degree in criminal justice. Ricky survived serving in combat zones in his over 20 years of military service, but he could not survive the VA and its negligent treatment of him. I have heard excuses. The guidelines are not standards of care, and some veterans who die of overdoses were suicidal. These are excuses that the VA is making because it has failed to take the action needed to fully implement and follow its own written guidelines that have already been published. Let me be clear. The VA knew that Ricky was not suicidal. The VA knew that Ricky did not display drug-seeking behavior. The VA knew Ricky wanted to reduce the amount of pain medication he was taking. It is all documented in Ricky's medical records. Humana and the VA have teamed up on a program called Project Hero. Last year, this committee heard the testimony of Brad Jones, Chief Operating Officer of Humana Healthcare Services. Mr. Jones contended that Humana and Project Hero provided a strong care coordination element This did not happen in my husband's case. No one at the VA or Humana monitored his drugs to ensure safety, nor questioned why he got all of the medications when he had a diagnosis of sleep apnea. I would like this committee to use its powers of investigation to uncover why Humana and Project Hero did not protect my husband, Ricky, from the lethal cocktail of drugs that killed him. Why can't the powerful computer systems at both the VA and Humana that process the medical records of our veterans be programmed to monitor the kind of drug interactions and dangerous conditions like sleep apnea to alert both doctors and pharmacists when dangerous prescribing occurs, like that killed Ricky? It is my understanding that when unexpected death occurs, the VA does an analysis to find out why the death occurred. I want to know if such an analysis was ever done in my husband's case and whether or not the VA will investigate my husband's death so that other veterans won't suffer the same fate. I hope the VA, and if not the VA, then this committee will ask these questions, learn something, and save the lives of our veterans in the future. This is the one way, the only way, that my husband will not have died in vain. I will not be silent about any of this. My husband does not have a voice, therefore I am his voice. I want to see that this overdrugging of our veterans stops and that there is accountability for these physicians' actions. I respectfully request that this committee demand that the VA follow its own written guidelines, demand that the VA put in place procedures that punish VA doctors and staff who do not follow the written guidelines, and demand that the VA and its doctors put a stop to this epidemic of the VA skyrocketing use of prescription painkillers to treat veterans. Thank you.
Thank you so much, Mrs. Green. I really appreciate your being here. Mr. Rentschler, could you proceed?
Chairman Benishek, Ranking Member Brownlee, and members of the subcommittee, I'm honored for the opportunity to speak to you today about my own experiences with the VA's pain management system, or lack thereof. Not only am I retired from the United States Army, in which I proudly served as an infantryman for 5.5 years, but as stated earlier, I currently walk alongside of other veterans struggling to navigate the difficult systems and trying to find a new normal life. After I was medically retired from injuries sustained from a mortar blast in 2004, I left the Army in 2007 and entered immediately into the care of the VA in 2008. I was on 8 different medications from Department of Defense that took 3 years for Army doctors to balance a safe mix with limited side effects to allow me to have an opportunity to try to function. I entered into work at the only thing I knew how to do as an infantryman. I started working corrections. With the VA care, my first practitioner informed me that many of the medications I was on were not on the VA's formulary and they had to find a new mix. They began experimenting on me. Despite the urging of my wife telling them that many of the medications they wanted to try again already failed through DOD, they did it anyway. Within 12 months of VA care, I was on 13 medications, many of which were to counter the effects of other medications, and I began to backslide in my recovery. It ended with me having a severe panic attack for the first time in my life while at work, resulting in the loss of my job, resulting in my family losing our house and our vehicle and being virtually homeless if it wasn't for our family stepping up and taking care of us. In 2009, I began to suffer from debilitating back pain as a result of my injuries. The VA's answer to that was to add narcotics into the mix of medications that I was on at the time. I was on Percocet. And what happened was, as I took that, the more I took it, the less it worked because my body became tolerant to it. I continued to ask my VA doctors to find a proactive solution for the back pain rather than more medications, and the answer was an increase in the dosage to the level of 12 to 15 5-milligram tablets a day. When that was no longer effective, I finally saw neurosurgery, who sent me to a physical therapist. I was excited for a proactive solution. However, when I received that care, it entailed me sitting in a chair while the physical therapist asked me questions about the pain and printed off a package of papers that included instructions on stretches to do at home on my own and asked me to follow up in 2 weeks. That made me feel hopeless and infuriated. When I began advocating strongly for my care at that point, my dosages maintained at the levels that they were, but they were augmented by other medications such as morphine and methadone. I began to not function well at all. I had children at the house and things were not going well at home. Finally, I was able to get an EMG and an MRI, which determined that I had severe nerve damage and resulted eventually in a fee-service referral to a private hospital. When I went to that private neurosurgeon, he asked me how long I'd experienced the symptoms, and I had told him it had been over a year since it was that bad, and he was infuriated at the VA for allowing it to take place that long. He scheduled an urgent surgery that took place 3 days later, and the result of the delay in my care meant that I had permanent nerve damage. I still have no feeling in my left leg to this day. I continue to take this cocktail of medications that the VA prescribed me, less than the narcotics, following the surgery. And there was no oversight. It took me 3 months to get an appointment with a primary care doctor that usually changed who the person was that I saw every 3 months when I got in there. Finally, I had a new prescriber in 2011, 3 years after I entered the system, who said, "Many of these drugs are harmful to kidney and liver. Let's get some blood work." The blood work determined that I had elevated liver enzymes to lethal levels. I immediately saw a hematologist who performed a biopsy and determined I had scarring of the liver and diagnosed me with non-alcoholic steatohepatitis. This prompted my wife and I to remove myself from all of my medications, save the seizure medications and as-needed migraines. This makes life very difficult. But within 6 months, my liver enzymes had returned to a high normal level. And I'd rather be pill-free and in pain than to die. I continue to have struggles. In 2011, the back pain returned, and I began pleading again for my own care, and I was denied everywhere I went. I went back through the hoops of physical therapy, occupational therapy, who, by the way, offered me a device to help me put my socks on in the morning. I was denied any other care that I was asked for. I turned to spending $15,000 out of my own money to buy a therapeutic hot tub and a massage chair, just hoping to find a way of managing my pain. I lived next door to a very nice lady who's a massage therapist who worked on me for free. These were the only ways I can manage my pain without the drugs. There's no happy ending to this account. I apologize. I'm currently taking narcotics again. I'm prescribed levels that allow me to take 6 5-milligram oxycodone a day. I can't take Percocet because of my liver. Let me emphasize, I did not make this trip here today to gain an advantage for myself. But I've walked alongside of countless veterans, and I know this to be true. It is a hopeless situation when you're encountered with this type of debilitating pain. The VA is very quick to drop statistics on 22 soldiers a day ending their lives. But they don't really look internally and realize that the hopelessness that comes at the very end for a veteran is when he reaches a level of debilitating pain that puts him into a hopeless situation at home. Being 30 years old and having to rely on a cane and a wheelchair and not being able to hold my child without physical pain is a hopeless situation. And when I cry out to the VA, my only source of medical care, to help me with this situation, and I'm hit with a brick wall and a bottle of pills, that does not end the hopelessness. And in fact, it makes it a more hopeful situation and results in the loss of life of countless of our veterans. I thank you for your time and your oversight on this matter, and I urge the VA to start looking internally for a solution to this epidemic.
Thank you very much, Mr. Rensler, for your testimony. I truly appreciate your comments. Mr. Minyard, please begin.
My name is Justin Minyard, and I would like to thank you for the opportunity to appear before the committee and address this vital subject. I'm a medically retired member of the United States Army. Before retiring due to a series of spinal injuries, I was a first responder at the Pentagon on 9/11 and a special operations interrogator. I struggled with years of dependence on the opioid therapy that was my only option, made available to me for my chronic debilitating back pain. Finally, after years of searching, I found lasting pain relief through spinal cord stimulation, or SCS. Today, I'm proud to say that I've not taken a single dose of opioid pain pills in the last 2 years. No veteran should have to struggle for as long as I did. Early access to interventionists in the VA is critical. I first developed chronic back pain when I was serving as a member of the Presidential Escort 3rd U.S. Infantry Old Guard, stationed at Fort Myer. On 9/11, my unit was one of the first responders at the Pentagon. For the next 72 hours, we searched for survivors, working on adrenaline to move huge pieces of rubble. As a result of these efforts, I sustained a serious back injury, damaging disc, and a fractured vertebrae. My back pain drastically impacted my life from September 11th onwards. In 2004 and 2007, I was deployed in the Middle East and re-injured my back during subsequent combat operations. When home on R&R, Army doctors told me my spine was rapidly deteriorating and I needed reconstructive back surgery. Despite knowing I should have the surgery, I wanted to complete the mission with my unit. My doctor responded, "If you insist on going, this is the only way that you will be able to make it through." Then he handed me a bottle of prescription opioid pain pills. My pain fluctuated daily somewhere between a 4 and a 9 on a 1 to 10 pain scale, but I was able to mask that due to the high dose of pain pills. It was a very double-edged sword. The pills allowed me to keep working, but they also allowed me to do further damage to my back. August 4, 2008 was my breaking point. I came back to our team house in Iraq after an extremely challenging 3-day mission. I stepped out of my Humvee, and my right leg simply gave out. I couldn't take another step, and it was terrifying. I was subsequently medevaced on a helicopter to Balad Air Force Base. Returning home, my life was not my life. I was in a great deal of pain, confined to a wheelchair, and struggling with severe PTSD. I also started an intense opioid pain medication regimen. My life revolved around, when is my next pill, when is my next dosage increase, and when can I get my next refill? At my worst point, I was taking enough pills daily to treat 4 terminally ill cancer patients. It had enormous physical and mental effects on me. I was so high on the opioids that my eyes would often roll in the back of my head, and if I wasn't babbling incoherently, I was drooling on myself. My wife stayed by my side throughout the entire process, but for years I went without even telling her thank you for taking care of me. I was not the husband my wife deserved, and I was not the father my daughter deserved, and it was a very dark and difficult part of my life, one of which I'm extremely ashamed of and regret today. With no options offered by the medical services, and after seeing a video of myself passed out with my daughter in my lap, I started to look for treatment on my own. I had a spinal fusion procedure that helped me regain some mobility, but did nothing to lessen my pain or dependence on opioid medication. It was a major challenge navigating the bureaucracy of the VA and DoD healthcare systems. My wife had to advocate for me, never taking no for an answer. Finally, we found an interventional pain specialist at Fort Bragg conducting a trial study of SCS therapy. I credit both with turning my life around. My specialist explained how an implantable device could stop my brain from receiving pain signals. After a test drive, I had the permanent device implanted in less the time than it takes to have a cavity filled. When the device was turned on, I was floored. With each adjustment to the device, I could feel the impulse moving through my body and hitting my targeted pain areas. All of a sudden, to push a button and have my pain drop significantly was life-changing. The relief I felt from SCS allowed me to start tapering my medications. That process took time and was extremely difficult, but it was worth it. I'm now at the point where I have not taken an opioid-based pain pill in more than 2 years. The bottom line is that I consider myself extremely lucky that I was able to push through the maze of providers and find a doctor knowledgeable about SCS. The majority of soldiers are not so lucky. Soldiers who lack the resources and awareness to advocate for alternatives to opioids and are left to the crushing reality of lifelong opioid dependence, or worse. A recent VA study spotlighted the horrific epidemic of suicide amongst veterans, 22 per day. We must increase awareness about alternatives to opioid pain medication in the VA system. The VA must work to create access to interventional pain specialists knowledgeable in state-of-the-art pain management treatment. We must train more doctors in these techniques and devote more resources to raising awareness. We should also begin collecting data on long-term outcomes of interventional therapies versus opioid therapies, so we have the numbers to show that the techniques that help me will help other soldiers as well. The VA is a great place to start because so many veterans come home and struggle, just as I did. I continue to struggle with the VA in getting timely appointments with a specialist to manage my SCS therapy. But my hope is that in the future, policies will be in place to help people like me manage their SCS therapy and to help shield soldiers and their families from the devastating effects of opioid dependence. Thank you very much for your time and for listening to my story.
Thank you, Mr. Minyard. I truly appreciate your comments. I yield myself 5 minutes for questions. Thank you all once again. I guess I have a question. Let me just start with Mrs. McDonald. Did your husband see the same person every time they went to the VA?
No, sir.
So was that person the regular primary care physician that they saw?
Both his pain management and his mental health management prescription bottles had the same doctor's name on them, but it was a rarity that he either saw them. It was a rarity that he saw the same doctor twice. Many times he came home from appointments frustrated because he, especially in mental health, had to basically relive the last 15 years and 5 deployments over and over and over again. And he never felt like that was ever going to be treatment for his PTSD. Like I said, almost immediately after seeking treatment, he was diagnosed with severe PTSD. In the July of 2011, just months before he died, he was awarded 80% disability after never having an MRI, x-rays, nothing to prove where this pain came from.
Mrs. Green, let me ask you the same question. Did your husband see the same person over and over again?
My husband had an assigned neurologist, a VA doctor, and then he also had a civilian doctor. So he had 2 neurologists, but he had other doctors that he did see at the Fort Smith VA clinic, in that he would see different health practitioners. So it could be a different number of.
Were you ever involved in asking the physician? Did you ever go with him to his appointments and ask about all these medications?
Yes, sir. I had attempted to go with him. They would not let me back with him into the room. Now, I did see his.
They wouldn't let you go with him to see the doctor? Is that what you're saying?
No, sir, they would not. Now, I did see his doctor with him when he had a spinal fusion in May of 2011, and I did see the doctor with him, and then the back surgery, I saw the doctor with him for the back surgery.
So neither one of your husbands actually saw a pain specialist then?
No, sir. My husband had never been referred to a pain specialist.
I had actually, just prior to my husband's death, when he went for his appointment on the 12th, I suggested to him that he talk to his doctor and allow me to talk to them, because I feared that the amount of medication that he was on was what was preventing us from conceiving, because he had completely deteriorated, not just as a person, but his health was going downhill. My husband was in stage 2 liver failure, which was only discovered by the coroner.
Unbelievable. Mr. Lancho, is that your experience as well? Did you see the same person?
No, sir, I did not see a pain specialist, and primary care often, as the deployment health team was attempting to shift focus, the primary care provider would often change from one appointment to the next.
Mr. Minyard?
Sir,
I want to know if did you see did you end up going Was this within the VA system, this pain
My
stimulation device?
chronic pain treatment both was in with DOD and the VA. I can tell you that before I was referred to a interventionalist pain specialist, I was already at the point where I was daily taking 240 milligrams of Oxycontin, 60 milligrams of oxycodone, and 40 milligrams of Valium a day, prescribed by my general practitioner, the same doctor that prescribed medicine if I have a cold or the strep throat. And that also alternated between, sometimes she decided to go with a 100 microgram fentanyl patch, again, which is typically used for patients that are not long for this world. So it was a long time before I was handed
Did it
off.
seem to any of you have the experience where the physician, or maybe not be aware that they were looking to get you to someone that could manage this better than they could, or they just couldn't get the appointment, or they just decided that they were going to do the management? Was there any? Did any of you remember any?
In my situation, sir, my primary care provider made it clear to me that she was my primary care provider, and it was her responsibility to manage my medication. If that can answer your question.
All right. I think I'm out of time now. I'll yield to Ms. Brownlee for 5 minutes of questions.
Thank you, Mr. Chair, and thank you all for being here, and thank you for your service to our country. And I think we all owe you, each and every one of you, a deep apologies for not responding to your needs the way you have defended our country. And Ms. McDonald, I include you in thanking you for your service to our country and being married to your spouse and supporting him through this process. That you too need to be thanked for your service. So thank you all. I think this is obviously a very, very important topic, and hearing your individual stories, I think, is important for the American people to hear. I wanted to ask a question, my first question anyway. I think in this question is more directed to Mr. Green and Mr. Rentschler, and I was wondering about your experiences and maybe experiences from other wounded warriors that you may know regarding the continuity of treatment from the Army to the VA, and perhaps from one VA facility to another VA facility.
I'll answer that to the best of my knowledge. Again, I've walked alongside of countless veterans over the last several years on a volunteer capacity and walked them through attempting to navigate the VA healthcare system to get the best care possible. In my experience, it takes quite often a door kicker mentality to get veterans the care that they need. I've hand walked them to a physician's door, to a social worker's door, to a mental health practitioner's door, and said, "This person needs help today." And that's the way we've been able to make some things happen in people's lives. To answer as quick as possible, no. There's not good continuity of care from one facility to another. There's not good continuity of care from DOD to VA. As I spoke on my specific experience leaving DOD and entering VA care, my medications weren't on the VA formulary, so they completely changed my medication regime, put me on more harmful medications, which ended up causing me a backslide in my recovery, which took the Army 3 years to establish. As far as there's a veteran that I work with currently that has left Portland VA facility in Oregon and moved into Washington State, and upon entering into Washington State American Lake VA hospital, he was told that his medications are not able to be purchased through the American Lake VA hospital because they don't have the budget for the non-formulary medication that the other facility had. And this was again a medication that took 6 years to figure out the best thing for him, and they're not going to purchase it anymore, which is causing him a backslide in his pain management as well. So the short answer is no, there's not good continuity of care.
Thank you. And I think I said Mr. Green. I apologize. I meant Mr. Minyard. If you had any additional comments in terms of continuity of treatment.
Ma'am, with all due respect, I would not, in my opinion and through my experience, I would not place the word continuity anywhere in a sentence that contains the other nouns DOD and VA. To give you a quick answer, the systems, to me,
I hear you.
don't work.
Thank you.
Yes, ma'am.
And then really to anyone who would like to respond, can you talk a little bit about to what extent with the VA facilities has there been any kind of sort of comprehensive interdisciplinary approach to your situation or to others that you might, we talk about a primary provider, therapists, others who are working as a team?
I guess I can say one thing about that. After my husband's death, I did contact the VA. Almost immediately, the VA itself told me that I needed to immediately start the process to claim my husband's death pension to help my family. What doing that immediately does, I don't know. It took 11 months to start receiving any retroactive pay from my husband's pension. I lost my home. I lost my car. When I asked them during the filing of the claim, the VA asked me whether I felt my husband's death was service-connected or not. First, that's not my decision. Every pill he put in his mouth was due to an ailment or injury he received either in theater due to his service for his country. So yes, that makes it service-connected. Why it took 9 months for them to make a decision and a rating on that? No, I was simply told, I'm sorry, Mrs. McDonald, this is the process. It takes time. There's a huge backlog. I feel like the VA right now is proud of themselves because they're saying the backlog is going down. The amount of claims are lessening. Well, of course they are, because they're dying. They're not receiving treatment anymore because they're not here to receive it. When I asked the VA, why? Why was his health care not well managed? And the response they gave me was that there was nothing else that they could have done and that his health care was well managed and properly maintained. No.
Thank you very much, and I yield back.
Mr. Hillskamp?
Thank you, Mr. Chairman. I'd like to also apologize, as my colleague has done, for what has occurred here. I had a couple follow-up questions that the chairman was asking, I think, in terms of continuity of care. And I was also struck by the denial of Ms. McDonald and Ms. Stowe Green for ability to walk in with your husband and participate in those appointments. Is that what I understood correctly, that you requested and the VA would say, nope, you can't come back and visit with...
Many a times I would go to the appointments with my husband in the very beginning of his treatment. I wanted to, first of all, he was in denial that he even had PTSD, like most soldiers and veterans, I think, battle with that probably more than the pain itself, is the denial behind the fact that they may actually have a mental health issue underlying a lot of the war that they've experienced. Once I was able to get him convinced that it actually took the help of another veteran to convince him he needed help. I did go for the first several months, and I had to wait in the waiting room. I was told that due to privacy issues, I wasn't allowed to be there with my husband. Now, in a civilian sector, doctors normally will allow a spouse to go back there just because, especially prescribing medication, once they've received that medication, they might not remember the orders that the doctor gave them afterwards of taking the medication. It was frustrating. I finally stopped going.
Did your husband request that you come in there, and they denied that? I'm just curious what the VA...
On the September 12th appointment, the day before he died, he requested that I be allowed to go with him to his... He was finally being scheduled to see a pain specialist at the Ohio State University Neurological Surgery Center for his back pain. a consultation, and they were going to allow me to be there. That would have been September 24th of 2012, but Scott was deceased by the 13th.
Ms. Green, was it a similar experience?
Somewhat. I was denied the right to go in with my husband, and he did want me in there, but they refused because of privacy issues.
Mr. Chairman, I would look forward to hearing what
This
the
is
VA
going
has to
on,
say,
and-
because this is, you want to be in there. The patient would like to see you in there in the VA. Do you think it was a preference of the physician or the provider, or you think that was just general
I
policy?
can't answer that. I can't speak. I don't know.
All right, thank you. How big were these clinics in terms of how many providers were there? Were these pretty massive clinics, or were small? Were you receiving care?
The clinic at the VA in Fort Smith is not a huge facility, but we do have a lot of returning servicemen and women, and it is utilized frequently from the Guard, a lot of transitioning soldiers. So, but it's not a very big facility.
Mm-hmm. And Ms. McDonald, when you were concerned on PTSD, how would they have handled that? You'd say you have to go see someone separately, or you could bring it up to the primary care physician if your husband was willing, and do you know how they would have handled that?
I don't know how they would have handled it. You know, my primary concern of telling him, look, flat out, I'm going with you. My husband never accused me of having the ability to keep my mouth shut. I was going with him regardless of what they said, because I had watched his medications fluctuate in such a way, especially for his PTSD. My husband was no longer Scott McDonald. I didn't know who the man was that I was married to. He had become angry and violent. And in the months prior to his death, we had finally thought we had found a remedy. And he was back to himself. He was back to being a father and a husband. But he had been labeled 80% disabled. He jokingly would say he didn't mind being a soccer dad. But I could see that he was broken.
Thank you. I yield back, Mr. Chairman.
Thank you, Mr. Hillscamp. We'll call upon Dr. Ruiz.
Thank you, Mr. Chairman. Thank you for your service. Thank you for all those days that you went wondering, and thank you for finding hope in your struggle to make sure that other people don't get treated like you did. I am an emergency medicine doctor, and I treat patients who come in when they're at their last wits, when they just can't take it anymore, when that pain is unbearable, they can't see their doctor, or it's just relentless. Can you tell me about the experiences? Did you ever have those moments where you sought care for acute pain, acute on that chronic pain at a different facility as an emergency department that wasn't affiliated with the VA? Yes.
No, because we quite frankly couldn't afford it. We utilized the VA because it's free health care for the first 5 years after separation from the military.
Okay.
And it's what we could afford.
How about the others?
The same answer. We honestly can't afford for that to happen. It took us a long time to recover from the financial hardships of losing my job. And once my benefits started, I couldn't afford to seek treatment elsewhere. We had to put together, as I said, a pain management regime that worked for us. We paid out of pocket for a while for chiropractic care, and we found somebody through church who would work on me chiropractically for free. And our neighbor's a massage therapist, and we found things that worked for us just to get by. But, you know, it would be really cool if the VA would take care of some of that too.
My husband always said that when he enlisted into the military, the VA had promised him his health care. And when he was VA service connected, he said he trusted the VA and that he was going to use the VA. And so his facilities that he utilized was the VA.
My understanding is that the VA will not cover acute emergencies outside of the VA in what they cover. Is that true or not true?
I cannot answer that.
Okay. My question also is referring to all those times that you mentioned that there was a doctor that would add a new medicine or that would change the dose, and that there's no continuity of care, like it's not the same doctor. Sometimes that may occur outside of a VA system or not, or inside. I know in this case it did occur on the inside, and sometimes that does occur on the outside. What was it like to get information from the VA to those doctors in terms of knowing what the medications they were on and what's the dose and what's the regimen that was prescribed? Because sometimes when you don't have that information, they see you for the very first time and there's no continuity, there's no history. They just look at a list of maybe what you've been on before, and so they'll prescribe you just to handle that specific situation. How is the ability to acquire records or call your physician from the VA?
Sir, I can try to answer that. I think it would be easier if everybody in this room, we all work together to try to raise the Titanic than try to get my medical records from the VA to a civilian hospital. And to have a doctor from the VA call my civilian provider, that would be unheard of, sir. In my experience, it's extremely difficult to get. It's kind of a chain link process. It's extremely difficult for me to get my DOD records into the VA. If that happens in piecemeal, once they do get to the VA, and I do need to go see a civilian provider, I have yet to receive documents that I asked for 12 months ago. And I volunteered to come to the VA where the records are kept, take time from work, and photocopy them myself. And we're at 12 months and counting, sir. It's extremely difficult.
I think for me, I was only able to obtain, and we're still in the process of obtaining my husband's full medical jacket after the estate hearing in which I was appointed the executor. I think the bigger question is why is there not more continuity between the doctors at the same VA?
Yeah.
Why is my husband being prescribed the same medication and 2 weeks later sees another doctor who says, don't take that, but then the same medications show up in our mailbox? My husband was just receiving pills left and right that it seemed like with every month that passed, the plastic bowl, mixing bowl that we kept all of his meds in had to become bigger because they just become so abundant. And nobody ever said, stop taking this one, switch to this one. It was, this doesn't come in that milligrams. Okay, so-and-so has, nobody was going through his records and saying, this doctor already gave you this, so I'm not going to go and do this. So I think there needs to be a lot more communication amongst the doctors who work in the exact same area, in the exact same field, and treat the exact same patient.
I absolutely agree with you, and I think that is the primary question here, is what kind of safety mechanisms are in place to ensure that a prescription cannot be prescribed until they have a consultation with the appropriate pain specialist, which we know that you have a lack of in the VA, and pharmacy, to start to have different ability to look at the interactions between drugs. There's a big push now, I know, in the hospital that I work in at Eisenhower Medical Center, where every patient, the nurses and the doctors have to get together and they have to look at the interactions and identify those interactions for every single drug that they take. I think these are approaches and policies that the VA may have. Like you mentioned, there are clinical guidelines, but it's the implementation. And what are the quality control measures that also look not only at the actual science of those interactions, but the patient-doctor relationship, not allowing the next of kin, the spouse, to be seen with the patient for privacy reason is one of the biggest hogwashes I've ever heard. And the other thing is to make sure that we look at pain in a holistic manner, to look at the complexity of pain, not only on the science, but also the effects of the interactions with family, their ability to function, their mental health, like you mentioned, and the perception of who they are as a human being. And I think that these are questions that we will be asking the VA and we'll be looking thoroughly into. So I thank you for giving voice to the voiceless, and although they're not voiceless, their voice lives in you. And I know that because I feel like your spouses are here, and I feel like all your friends that are doing that are here with you. So thank you very much.
Thank you, Doctor. Now I'll have 5 minutes from Dr. Wenstrup.
Thank you, Mr. Chairman, and I, like the others, applaud you for being here and to have the courage to be here and to take up this new mission in life. As basically the things that I was going to bring up, my colleague Dr. Ruiz really pretty much covered. And as a caregiver and as one that has given care in the DoD, I'm an Army Reservist, I understand that side of it and the complexities that are with it. And it bothers me when we hear what we just heard, because this couldn't go on, I don't think, very well in the civilian side, the things that are taking place. And so my question to sort of piggyback on Dr. Ruiz is, when you went to the doctor, you or your spouse, did they ever take the time to review the current medicines while prescribing something new that you're aware of?
My husband went to the VA doctor in September, a month before his death, to request that his medications be reviewed. And how the healthcare provider reviewed it was to tell him that he should continue taking all of his medications. And wrote that in the medical summary, and it's clear in the medical summary of his medical records. And he followed the orders of the doctor.
Is that similar for all of you? I would imagine that.
I think she paints a pretty good picture of what it feels like and the transition that I had to take for myself in learning how to advocate. And I learned it pretty good from my wife. She's about 5'5", but she's a pistol. When we would go into the hospital and the doctors would say, "You're going to take this pill," it would be like, "Yes, sir. It's going to help me." As far as reviewing the medications, every visit they would print off at the nurse's station a current list of medications, not necessarily to go over them or to ask how they're doing, but I'm sure that this comes down to a policy issue. This is how they're executing the policy to review those medications. At each visit, the doctor prints off a current list of medications and hands it to me as we're walking out the door. I think a big issue that I'd like to raise as we're talking about this specifically is the oversight. Many of these medications have harmful side effects, and the problem that arises, I'm sure in the civilian community, that the primary care providers change and they move. But this happens really frequently at our VA facilities. It happens, they go from team to team, and when you're put on a new medication with harmful side effects and there's no oversight to say, "Hey, how is this doing for you 3 days later?" That's a dangerous practice.
That goes to my next question. When you were receiving your medications, was there ever a consultation with a pharmacist to discuss the medications that you're on?
That's another practice, at least at our facility, is that when you pick up your medications, if it's a new or renewal, we have to sit in front of the pharmacist who looks it up, and at our facility they say, "This is the medication that you're getting, and these are some of the known side effects," and they've printed off a fact sheet for the medications and then prescribed them to me. So,
Were you ever offered a consultation with pain management specialists?
no.
Mr. Minyard?
Sir, I took it upon myself to try to track down the pain specialist in our VA. Nobody could tell me what office he was in, so I literally walked the 3 or 4 floors of the VA office to office asking who the pain specialist was. Once I got there, I quickly realized it was an exercise in futility because his answers for my condition and my injuries were either go back on long-term opioid-based treatment regimen, or he could do lumbar epidural shots. I mentioned that I had a spinal cord stimulator already implanted, and it helped me. It was instrumental in stopping a dose of opioids that would have killed me very shortly. And this is, now to put this in perspective, this is the interventionalist pain specialist in charge of one of the largest VAs in Florida. The guy that we all are supposed to go to for pain management. He had never heard of a spinal cord stimulator. That blows my mind. That, to me, is beyond unacceptable. And for me as a patient to have to pull out a brochure and say, this is what it does, doctor. And I did it very tactfully and very respectfully, but for me, I'm an Army guy, and I'm having to talk to a medical professional and explain a device that's used to treat pain, the field in which he has gone above and beyond to become educated in. And the most absurd part of it is, I was thrown out of the office. The reception I got from him was, again, you're an Army guy, I'm the pain specialist, how are you going to teach me anything? Here's your brochure, thank you very much, have a nice day. That was my situation, which is absurd, sir, in my opinion.
Agreed. My time has expired. I want to thank you all very much. Appreciate it.
Thank you, Doctor. Ms. Custer?
Thank you very much, and thank you, Mr. Chairman, for holding this hearing, and to our colleagues, particularly our doctor colleagues. I want to say that we're fortunate to have their expertise on this panel. I just want to say, in addition to thanking you all for your courage to come forward today, and please know that you are giving voice to your spouses, and for you all, for your service, thank you, and for coming forward. I have been married for 27 years to a man who lives with chronic pain, not for military purposes, but I very much understand the story that all 4 of you have told, and it's something that I've lived with every day, and the psychological impact and the physical impact. But I want to focus on, Mr. Minyard, your experience with this spinal cord stimulator, and just for me to understand as a new member of Congress how that type of answer to your prayers could be made available to more people in the VA system. And I know it's complicated managing pain. For my husband, he's tried every treatment that you've described and many that you haven't. He now is getting hip replacement surgery where people had talked about major back surgery, and in fact, this is one of the first times that I've seen him pain-free. So I think it is complex in terms of the connections, but how to get from this opportunity that you had for more people across the spectrum to have these types of cutting-edge therapies that could make a tremendous difference in people's lives. Do you have any suggestions for that?
Yes, ma'am. And I'm very grateful for the question, and I'll try to answer it as best as I can as a patient with the device and that it works. Obviously not an industry expert or anything like that, or a policymaker, but the biggest stumbling block to getting this medical innovation, technology like this, that I've seen, and when I deal with other veterans and other people that are dependent and addicted, as I was, to Oxycontin, is, or opioid pain medication, is that providers as well as patients have to be educated. That's, for me, if I ran the world, that's where I would start. Because if you don't know about it, you can't teach somebody about it. So if more doctors were made aware and learned about the technology, and it doesn't just have to be what I have, but it's medical innovation, looking for a better, more effective way to treat veterans and other chronic pain sufferers, not just veterans. So it's, in my opinion, again, ma'am, it's not being satisfied with the status quo of, we've been doing opioid pain medication for long-term chronic pain treatment. It seems to be going okay, so let's stick with that. Why not strive to do something better? And the ramifications of long-term opioid-based pain medication, if you look at the I spoke about this yesterday, a lot of times you hear the argument, there's a cost-benefit ratio. Pain pills are, I'm assuming, much cheaper than technology like this. But cost-benefit analysis is not really realistic when you're looking at, if you want to do cost-benefit analysis, we can do that. Let's go ahead and what cost are you going to put on my marriage, my ability to now know my daughter, who I didn't know for 3 years because I was stoned and I was deployed? What value is there for me to be excited to read a book with my daughter at story time, at bedtime? What value do you place on me being happy and excited about my 10-year anniversary on Saturday? I didn't think there was any way I could make it to 10 years. If I was my wife, I would have divorced me 20 times ago. But the point is, it has to, in my opinion, it has to start with education and the desire to look beyond the standard and the status quo. It seems to me every other car industries, for example, they don't settle for this year's model is the best we're going to do, and we're good with it. They constantly strive to look for new innovations, better ways to sell their product. Why don't we do the same thing with patients? Look for more effective ways for them to live well, have a family, be a productive member of society, and manage their pain as opposed to their pain managing them, ma'am.
Thank you very much. My time is up, but in the civilian side, there is a process, and I'm sure Dr. Wenstrup is familiar with the quality assurance, and it's something that we could look into of trying to get to a place where these situations didn't happen. So thank you so much for coming here today and sharing with us.
Thank you. Mr. Bilirakis?
Thank you, Doctor. I appreciate it very much, and I want to thank you all for your service. Appreciate it. Thank you for your willingness to testify as well. Mr. Minyard, I have one question. I understand at one point you went to VA with a list of private sector providers in your area who were able to see you and could provide the treatment you needed, and were told by the VA that you could not access care in the community and would instead need to travel to another VA facility hours away. Is this true and again, it would take months for you to get the next available appointment, which I think is unacceptable. Please describe that experience for us, and why did the VA tell you that you could not be seen in the community? I think this is a very important question. So please, if you will, thanks.
Yes, sir. Part of the technology I have in the pain therapy I have is treated by spinal cord stimulation. The Orlando VA, as I said earlier, the pain doctor there was not even aware of this treatment, and I went on Google Maps, looked up 60 providers within a 10-mile radius of the Orlando VA, civilian providers, that could give me the support I needed to maintain the device I used to manage my pain without opioids. I went to the highest, I started at the bottom and went up the chain of command at the Orlando VA, and then asked for the appeal to be sent up to Gainesville, saying, why can I not go? Why, with bonuses being paid to VA CEOs for outstanding performance when people are dying in the hospitals, why with big, conventions being thrown that cost millions of dollars, why can't somebody pay for me just to go down the street and get my device fixed? And they said no, it costs too much. We have a doctor in Gainesville, I live in Orlando, that deals with this type of thing. So I said, okay, can we get an appointment? And this was last May. They said, okay, we'll put you on the list.
So you have a doctor at the VA in Gainesville?
In Gainesville.
Yeah, okay.
I will see that doctor June of 2014. I made that appointment May of 2013. So I'm eagerly looking forward to it next year, sir.
So, in other words, there are several, you said close to 60 providers, private sector providers in the area that could see you almost immediately.
And on top of that, sir, I know our time's getting short, but due to multiple TBI injuries, one too many times being blown up, I have seizure disorder. The result of that is I have fairly frequent seizures, typically 3 to 4 every 5 months. So my license gets revoked every 6 months. I have a seizure. So that was another case I brought up with the VA, saying you would rather me try to arrange a ride from Orlando to Gainesville. But at the same time, I have a full-time job, which I was subsequently fired from because the VA kept canceling my appointments, and that's another story. But knowing I did not have a driver's license, they still insisted that I was not allowed to go 5 miles from my home to a civilian doctor. Instead, I would wait until an appointment was available, and then they actually called me, and their words were, "We need you to arrange some transportation. Don't you have a wife?" My wife is a VP for a Fortune 500 company. She's taken care of me, my daughter, and progressed in her career unbelievably. So, yes, sir, I do have a daughter, or a wife, but I'm not asking her to take time off to drive me to Gainesville when you can send me 5 minutes away. And that was that situation you're referring to, sir. If it didn't happen to me, I would have trouble believing it, sir.
All right, thank you. Anyone else want to comment on that on the panel? But also, I'd like, if you don't mind, I'd like to talk to you further after the hearing.
Yes, sir. It'd be my pleasure.
Okay, please. Please, anyone else want to comment on this particular issue?
My husband was referred to for a sleep apnea test, and there is a sleep facility in Fort Smith, and the referral was for Missouri. We had to take him to Missouri for his sleep apnea test. Not once, but twice, when there is a sleep facility in Fort Smith, Arkansas. Twice.
Thank you very much. I yield back the balance of my time. Thank you.
Dr. Harris? Thank you very much. I want to thank the chair and ranking member, other members of the committee to let me sit in on this. As you know, I'm an anesthesiologist, so pain management, although not my subspecialty, is certainly related. And I have a couple of very brief questions. Sergeant Renschuler, is that? I'm sorry, Rentschler, Sergeant Rentschler. Let me ask you a question about the denial by the formulary of Lyrica, which I find fascinating because, you know, federal employees can get Lyrica. I mean, you can go on all kinds of health coverage to get Lyrica. But my question is very specific. My understanding is, by your testimony, the chief of neurosurgery said you should get Lyrica. And then it was denied by the pharmacist, by someone. Did someone examine you from the pharmacy, sit down, take a history, maybe go over the indications, possible indications? Or was this just a paper denial as far as you know?
Sir, it's a disgusting situation, and it went down like this. I went up to visit the chief of neurosurgery in the Seattle Medical Center. She came up with this medication option, said it might be a really great thing to improve my quality of life and reduce the dependence on opiate-based medications, which is was a big goal for me. And it had very few side effects, and it certainly was not damaging to the liver. So it was a great thing for me and my wife. When she did tell me it was non-formulary, and it might be a battle to get it, but she was pretty confident that her rank would allow us to get this. It was denied, and she called me on the phone and told me it was denied, but she was gathering the signatures from 2 other department heads to resubmit a request back to the pharmacy, because when they responded to her, they told her he should try things such as lidocaine ointment and gabapentin.
And again, because I think you've answered the question, it was recommended by someone who never met you,
never met me, never evaluated
me,
and didn't know the specifics.
And my belief is, as I'm sure you share, this was because Lyrica actually costs more than other medications, right? So it's just cost-saving measure. It's just fascinating. That's fascinating to me. And just very briefly, Sergeant Minyard, let me just ask you, because you know, part of your testimony was pretty. As you've found out, pain management can get pretty specific, require a lot, and we require a high level of training, because you couldn't find someone in the VA system who actually nearby who could do what you had, which, as you found out, is pretty standard in the outside world. I mean, 6, 7 years ago, when I was giving anesthesia for patients like you who were getting spinal cord stimulators implanted. When you were in overseas, though, were you getting epidural steroid injections in a tent in Iraq? I mean, I'm an OB anesthesiologist. I've given thousands of epidurals to patients in labor. I would never dream of doing epidural steroids on a pain patient, because you actually need some special training to do it properly. But is that what you were getting? Were you getting epidural steroid injections?
Yes, sir.
I mean, and again,
I don't want to sound...
This is a VA hearing. It's not on DOD. Obviously, the DOD
sir.
was responsible for delivering that. But I think the appreciation is that perhaps even system-wide, not even just the VA, maybe in the DOD, I mean, there may be no appreciation for how the treatment of pain has changed over time. Multimodality. I mean, epidural steroids may well have been indicated in your case, but doing it in a tent in Iraq. I mean, this
not even a tent, sir.
I'm being generous.
Yes, sir.
It was a tent, but
I mean,
you know
what
what I
happened
mean?
first?
I'm sure you didn't have an interventional pain management specialist doing that intervention.
Sir, the docs that perform those, what would happen is I'd have my team's trucks rolled up outside the team house ready to go. As soon as all pre-combat checks were done, I went around the corner to a small enclosed area, 3 walls enclosed, and the RN that was attached to our trauma team would give me my epidural, and we'd wait a few minutes to make sure everything was good, and then I'd put on my combat kit and roll on that mission. I had 8 of those.
I'm going to apologize for the way the U.S. government handled that. Thank you very much, Mr. Chairman.
Thank you, Doctor. Well, it was particularly frustrating to me to hear your many stories one after another, but the challenges that you've addressed here seem to be markedly similar for each of you. I hope that the administration officials that are here listened as closely as I did to the testimony. And if there's no further questions, the first panel is not excused. Thank you all so very much. I'll now welcome the second panel to the witness table. Joining us on the second panel is Dr. Pamela Gray. Dr. Gray is a former provider at the Hampton VA Medical Center. Also, our second panel is Dr. Claudia Bohoric. Is I saying that right? Dr. Bohoric is a provider with the VA's interim staffing program. In that capacity, she's worked at 13 different VA medical facilities across the country. She is also a disabled veteran, so thank you, ma'am, for your service. We are also joined by Dr. Stephen Scott, the Chief of Physical Medicine and Rehab Services at the James A. Haley Veterans Hospital in Tampa, Florida. Thank you all for being here and for your hard work on behalf of our service members and veterans. We'll begin with Dr. Gray. Dr. Gray, please proceed with your testimony.
Thank you. At the outset, I'd like to thank the members of this committee on Veterans Affairs for offering me this opportunity. I am grateful for your time. I must also tell you that I am most honored to be in the presence of the 4 individuals who occupied these seats ahead of us. I would beg of this committee to hear their stories and realize that they represent tens of thousands of similar stories. Tens of thousands. I have included for your review today a letter that I wrote to my state senator. I don't mean at all for you to be bored by the trivial details of that letter. I use it as a jumping off point for you to hear the physician side of what it was like, at least at one VA center in Hampton, Virginia, between 2008 and 2010, when I tried to work through the system and failed. As a result of trying to work through the system and realizing the gravity of these complaints and the validity of my concerns, I offered myself up as a sacrificial lamb. When you are employed as a physician, you are prohibited at a VA medical center from speaking out to the general public. You are to work through chain of command. I did so, and it fell on deaf ears. I went to my state senator knowing that the inevitable outcome would be to be terminated, which was indeed the case. But it was only through doing that that my story was discovered. And I would like you to understand how I am here today. I went through appropriate chain of command, went to service chiefs, chief of staff, director of the center, represented my VA at a VISN 1 through 11 conference on pain. I went through all the appropriate channels and failed. I am here because of the investigative reporting of a CBS News producer, and for that I am grateful. I would pray of this committee. No, I would beg of you to offer constructive intervention. Your flowery words of praise, thanks, condolence are heartfelt, I am quite sure, and they are eloquent. But if true change and action does not come out of this committee, all here have failed. With that in mind, I'm going to use just some highlights of my letter to my senator, not for details, and yes, there are names in that letter, and I chose to let them stay. I see no point in mentioning them in this testimony, but they are in the written form. I do that because I spoke the truth then, and I speak the truth now. I am a physician with 30 years experience. I'm an internist and a rheumatologist. I closed my private practice and went to the VA in 2008. I never misrepresented myself. I am an internist and a rheumatologist. And I had a dual appointment with internal medicine, 30%, and primary care, 70%. In the first hour of my first day, I was informed that I was head of pain management. In my 10 years of postgraduate training, I had no pain management training. It is an entity unto itself, and it is a subspecialty that has subspecialty training. I was never asked if I was willing to assume this role. I was informed. So to those observations and questions that came before, I was pain management with zero training. My concern about that was it is not standard of care. If you're going to portray yourself as an obstetrician, you should have OBGYN training. A surgeon should have surgical training. That is common sense. The VA in Hampton obviously did not realize that. I tried to do what was asked of me. I thought it would be reasonable. They had no pain management, no rheumatologist, and so I decided to try and work through the system. I went through service chiefs, clinic nurses, telecare nurses, supervisors, when I discovered aberrancies in the way of treating musculoskeletal pain syndromes. I pointed out that 10 to 20% of opioid users become addicted. We were creating addicts. All of this fell on deaf ears. The chairman of the Department of Internal Medicine gave me this response to my query as to why we were writing so many prescriptions for opioids. Quote, "Think twice before refusing to write these narcotics. It's a time of economic downturn." I do not know if that was a threat of the loss of my job or if it alluded to the possible diversion of narcotics. I do not know. During my 2-year period, I was coerced to writing drugs that I knew in my medical experience were wrong. When I would object, I was simply told to do it or else. The physicians are given 3 choices. 1 is acquiesce and keep your job. 2 is quit. And 3 physicians quit during my 2 years there, 1 within 30 days of being hired, due to objection to writing these massive amounts of opioids. I chose to work within the system, which led to termination, the 3rd choice. I documented in my notes, in 30 years of practice, I know how to write a note, I know how to be complete. I included the facts. I was being coerced by non-medical employees, non-MDs, to write for large amounts of opioids. When that was discovered in my medical note, which was an electronic medical record, I was ordered to delete the note or alter the note. I had reported the truth and I refused. The chief of the Department of Primary Care altered my note, buried the note, which documented the truth, and I had the proof. I had the original note and then the subsequent note that was entered into the chart, and I reported that to the Office of Regional Counsel at McGuire in Richmond, Virginia. Nothing came of it. Again, I was trying to work through the system, which is what was appropriate. Upon representing my VA at the National Pain Conference, which was 2009, I brought all of that information back to both service chiefs, the chief of staff, the director, and in the 2 years after that time frame, nothing was implemented. Absolutely nothing. I became an advocate for several of the patients. There are patients who are smart enough to know about spinal stimulators, about alternate treatments, and as a result of trying to be a patient advocate, I was threatened with further action may result in disciplinary action to include removal. So again, the system failed me. I received death threats from patients. I was called before a probationary review board, not told of the charges against me, not allowed to review my records, and my chief denied knowing anything about this review board when she herself had called for it. So during my 2 years, I was forced to do work for which I had no professional training. I was ordered by supervisors to write large amounts of Schedule II narcotics for inappropriate medical circumstances. I had my medical records altered to hide factual documentation. I received sexual harassment by a male nurse who would come to my office during lunch hour and threaten me if I did not write for the opioids. And when I reported it, I was asked if there were any other witnesses. Since there were no witnesses but the two of us in clinic during lunch hour, ergo, it didn't happen. I was reprimanded for standing up for the rights of a patient. I was threatened to be reported to the National Data Bank, which is a mechanism for egregious complaints against physicians, and you have to reach a certain level of severity to be reported, and I did not, but they gave me that threat. And I was subjected to situations of entrapment, trying to get me to admit to things that were not true in an effort to build the case against me. I underwent that board. I was never apprised of the findings. I was called to my boss's office and terminated. I can see that I am over time, but I would like to beg, if I may, offer the 11 patients that are at the end of this letter, and I will go through them quickly. The bottom line in all of them are they are on massive amounts of medication. You don't have to know anything about medicine. You don't have to know the difference between morphine and tramadol and Percocet. All you have to do is hear the quantities. There was a 55-year-old man, the first patient I saw in this musculoskeletal clinic, who had carpal tunnel. I bet you everyone here has had carpal tunnel symptoms. If you flex your hand for too long, these fingers will go a little numb. It is fixable with surgery. This gentleman had the surgery. He had none of the findings of chronic entrapment of the nerve. He had morphine, fentanyl patch, tramadol, Percocet. He had been getting it since 2004. He had not been seen since 2004. He had had no labs checked since 2004. He had the opioids mailed to him. He didn't even have to come in. You had 2 veterans tell you about liver dysfunction as a result of these drugs. You must check the labs. There is not a civilian pain management, musculoskeletal clinic, rheumatologist, primary care, anything that would do this to a patient. I can go through them all. I am over my time. This is representative.
I truly appreciate your testimony, Dr. Gray, but time is a precious thing here in Congress, and I just want to make sure that everyone has the opportunity to testify. We will certainly conclude the statement, your written statement, in the record.
Thank you.
I appreciate your efforts here. Dr. Bahorik?
I'm here because...
Just pushed a little red
Can you hear me now? Okay. I'm here because no one else will speak out. My colleagues are afraid for their jobs. I'm here as a physician who's concerned about the health and welfare of our vets. I also happen to be a physician acupuncturist and a licensed physical therapist. I'm here too because, as he said, I'm a disabled vet. We've been asked to discuss the problem of narcotic prescriptions within the VA. I'm here to tell you that the system is broken, that it's a setup for catastrophe. at least on the part of the veterans who get caught up in the pain game. As a traveling physician, I've worked in 13 VA facilities from Guam to Maine, including the notorious VA in Jackson, Mississippi. Jackson serves as a perfect example of a system gone haywire. This was a system so cavalier that this VA facility didn't think the Drug Enforcement Agency rules applied to it. So when the DEA stopped all the nurse practitioners from writing narcotics, the VA traveling docs were asked to help, and I volunteered. I arrived to discover that I had been assigned the job of writing narcotic prescriptions for the vets that needed their monthly renewals. The first thing the head administrator told us was that we only had to review the charts, make sure they were stable, and write the prescriptions. He said he could do 30 charts a day himself while he was still playing top dog. He didn't understand why I objected, why I insisted I needed time to take a history, to examine the vets, and to review the chart. This is the same administrator that thought his own staff should write narcotic prescriptions on patients they never saw. He also paid medical residents at night to review charts on patients sight unseen so the pill mill could churn out more narcotics. So they stuck me in a tiny exam room with no exam table, so I couldn't examine the vets. They gave me a nurse and we set out to screen the vets. What I found was a disgrace. I discovered that veterans' narcotic prescriptions were being renewed month after month, months on end, sometimes for 1 to 2 years, without an examination of the body part that was in pain. They had been seen for routine medical problems, but the pain evaluation amounted to merely asking them to rate the pain on a scale of 1 to 10. This was not just a few of the nurse practitioners whose patients I saw. It was the rule rather than the exception. Often there were no x-rays, no recent MRIs, no tests, no specialist consultations for the pain problem, just more and more narcotics on top of other medications. There was no true attempt to screen for misuse or drug diversion. I found that urine tox screens were infrequently done, and often they were positive for substances like cocaine and pot, or negative when they should have been positive. Many of the vets were misdiagnosed. Some had potentially serious conditions. Pain contracts were not being completed. When urine drug screening was done, no one even checked to see if the specimen was body temperature or if the specimen was even from the veteran. No one was bothering to call the state data banks to see how many providers in the state were giving the people narcotics. I'm here to tell you that this is just not a problem at Jackson. It's endemic throughout the VA, where quick and cheap is rewarded over good and thorough. Furthermore, it is not uncommon for a doctor to refuse to write a narcotic prescription only to have the vet go to the administration. What happens? The administrators call another doc and tell them to write the prescription, or the vet will go to the emergency room to get their narcotics. Worse yet, doctors are being verbally abused, attacked, or injured when veterans who are in dangerous concoctions of mind-altering substances are cut off. In Jackson, a doctor was shot and killed. Another one had acid thrown in her face. In Delaware, 2 mental health workers were attacked. A vet who was denied narcotics ran his truck into the VA clinic in Lincoln, Maine. Another vet in Maine attempted to enter the VA with a gun to shoot the administrator. He became a case of suicide by cop. Why is this happening? Unfortunately, we have given the veterans the impression that for whatever problem they have, we have a pill to help it. 1 or 2 pills for depression, 1 for anxiety, 1 or 2 for sleep, 1 for PTSD, then add a few more pills for problems like hypertension or diabetes, asthma, then add 1 or 2 or 3 prescriptions for narcotics. What happens if the vet adds some over-the-counter medications, or if he drinks alcohol? We have a prescription for chemical lobotomy, a veteran who is at risk for fatal interactions, someone whose brain is bathed in a chemical soup. The VA will show you guidelines and resources available to providers showing how much they are doing. These are the same administrators that create regulations, mandates, requirements that are so mind-boggling that physicians are no longer captain of their ships. Basic principles of medicine are abandoned. Primary care providers are struggling to stay afloat in a system bogged down with mismanagement, bonuses that reward cheap care, not true quality care, and policies that make it nearly impossible to adequately and safely monitor the health care given to the brave men and women who served our country. Thank you.
Thank you for your testimony. Dr. Scott, would you please begin?
I just want to begin by expressing my sincere sympathy to Mrs. McDonald and Mrs. Green who are here, and to you and your families. I just want to express that before I begin my testimony. Good morning, Chairman Benešek, Ranking Member Brownlee, and members of the committee. Thank you for the opportunity to participate in this oversight hearing and to discuss specifically the Department of Veterans James A. Haley Veterans Hospital Chronic Pain Rehabilitation Program in Tampa, Florida, that treats veterans experiencing acute and chronic pain. VA's Chronic Pain Rehabilitation Program was established in 1988. Our involvement in this program over the last 25 years is a demonstration of our commitment to addressing pain management. We recognize that chronic pain can be a very disabling, and these veterans need our help. Chronic pain does not resolve within 3 to 6 months. When chronic pain causes significant psychosocial dysfunction, then it's called chronic pain syndrome. Chronic pain syndrome is defined as chronic pain with significant psychosocial dysfunction. While pain may be the cause of these psychosocial problems, there is evidence that once established, these related problems linger, even if the underlying pain is substantially reduced. Unfortunately, many individuals with chronic pain syndrome attempt to fight these problems using increasing amounts of opioid analgesics. But these efforts are rarely successful. Due to the complexity of the syndrome, no single treatment approach is the answer. A multidisciplinary and multimodality approach is almost always necessary. Tampa VA has both an inpatient and outpatient chronic rehabilitation program and has the only VA chronic pain program. The program is specifically designed to treat veterans and active duty military personnel with chronic pain. The program is evidence-based, intensive, interdisciplinary, 19-day inpatient chronic pain treatment program that targets not only the pain intensity, but also all the symptoms of chronic pain syndrome. The core philosophy of this program recognizes the complex interactions between the pathophysiological, emotional, social, perceptual, cultural, situation components of chronic pain. Approximately half the patients admitted to this program are taking opioids and approximately half are not. The program teaches pain self-management principles, where the participants assume responsibility for their daily functioning and learn to actively manage their pain. For most participants, this includes increasing their level of independent functioning, increasing their activity levels, reducing their emotional distress associated with chronic pain, eliminating their reliance on opioid analgesics or muscle relaxers, reducing pain intensity, improving marital, family, and social relationships, improving vocational and recreational opportunities, and improving their overall quality of life. A unique aspect of this program is that all participants taking opioid analgesics at admission are tapered off these medications during the course of the treatment. We have found that patients taken off these opioids experience similar improvements to patients who are not taking opioids in all areas of treatment outcomes over time, including pain severity, activities of daily living, mobility, and all other psychosocial problems. In its 25 years of existence, the programs and its staff have received numerous awards. The program has been recognized as a 2-time Clinical Center of Excellence by the American Pain Society. It has also received the prestigious Secretary of Veterans Affairs Olin T. Award for Clinical Excellence and has been accredited 6 times by the Commission of Accreditation of Rehabilitation Facilities, or CARF. The program leaders have been actively involved in promoting system-wide enhancement in VA pain care. As the most specialized chronic inpatient pain treatment option in the VA healthcare system, the program has already accepted and treated referrals from all 50 states, Puerto Rico, and the United States, Virgin Islands, and military installations around the world. In 2009, the chronic pain program was selected to serve as VA's training site for interdisciplinary pain programs. To date, we have hosted 30 teams from across the country to observe the Tampa VA model system and learn how to enhance pain treatment services at their facilities. The training program helps meet the 2009 VHA Pain Management Directive, mandating interdisciplinary CARF-accredited pain programs in each division integrated support network. The positive effects of these training are seen in the increase from 2 CARF-accredited programs in 2009 to 8 CARF-accredited programs in 2013, and it's anticipated that an additional 14 VA chronic pain programs will achieve CARF accreditation. Mr. Chairman, VA is committed to providing a high quality of care that our veterans have earned and deserve. I appreciate the opportunity to appear before you today to discuss the Tampa VA Chronic Pain Rehabilitation Program, and I'm grateful for your support in identifying and resolving challenges as we find new ways to care for veterans. I'm prepared to respond to your questions that you may have.
Thank you very much, Dr. Scott. I'm going to yield myself 5 minutes to ask some questions. Dr. Gray, it's my understanding that each VA medical center is supposed to have a pain specialist. So I guess the pain specialist that your VA medical center had was you then, right? I mean, you were the one that was called the pain specialist even though you had no experience. Is that correct?
Correct.
And now, was it you that testified that your records were changed?
Correct.
You know, that is a very much of a fear that I have about the electronic medical records, because I know myself at the VA, I experienced that as well. You know, I had a path report that said it was benign, and then the patient, so I sent the patient home for 6 weeks, and then I come back, the same path report had mysteriously changed to become malignant. But yet I had no evidence that there was a path report 6 weeks ago that said benign. So, you know, it makes you look bad. And this situation where you're saying how the medical record has changed, was there any evidence in the medical record that it had been changed without your consent?
Absolutely. Not that it was changed without my consent. Because I had been ordered by my superior to alter my note, and I had documented the truth, I refused. I took it upon myself to print my note.
Good idea.
The electronic medical records can't be entered into other than the treating physician or someone who has a pass level, and it could be a medical records person. My chair, who ordered me to change my record, was chief of medical records. She deleted the entire segment that she had ordered me to change. So the note started with my verbiage, ended with my verbiage, was signed with my signature. There was no record, and then reprinted, entered into the record as such. I printed that one too.
So you have a record of the
Yes, sir.
previous, the pre and the post.
Yes, sir.
Well, I wish I would have copied that path report. To tell you the truth, this is a real scary thing for me to tell you, because of the fact that here we got government-controlled health care, where administrators are going to be changing the physician's notes to make themselves look good. It's a pretty scary situation in my estimation. Dr. Bahorak, you relate a very similar story about being told how to treat patients by people that aren't physicians. Is that correct?
Yes, it certainly is. Administrators that are not physicians are often in positions to supervise us and tell us what to do. Not only that, she was talking about pain specialist. For instance, at Wilmington in Delaware, the pain specialist is not a physician, it's a nurse practitioner who tells us what to do. And the other problem with a pain specialist is if the person does get sent to a pain specialist, once they start them on narcotics, they actually dump them back on primary care and expect us to continue the prescriptions. They just want to do their procedures and injections, and they don't want to bother with the mundane work of the day-to-day monitoring people on narcotics.
Dr. Scott, let me ask you this question. It sounds as if you have a pretty dynamic pain specialty service there in the VA at Tampa. Do you have any experience with the way they manage pain elsewhere in the VA? I mean, it seems to me that you should be an example to the VA as how pain management should occur. It doesn't seem from the testimony we've had today that is actually happening.
We're trying to, because we set up this, we're trying to get other centers to come and educate them at our centers with team-to-team type interactions, and we've had 30 of them that actually have come. This program is real unique, because I actually have seen individuals, I've been in this program long enough, it's 25 years, so you can imagine, I've been in 23 years of this program, that have actually seen veterans from D-Day, they've had chronic pain. I've seen veterans that have had chronic pain from Korea, from frostbite and that. I've seen veterans from Vietnam. I've seen veterans from Gulf War I. I've seen complex veterans that have polytrauma, chronic pain from this war, and then some of those invisible type wounds where we have seen those too, and they've all been successful. in this, and they've all done well. And we have a program when you do this CARF stuff, it's an outcome based. So we're constantly, every day, everybody in the team is trying to improve the process, improve the program. And over 25 years, this thing's been polished off and is really a fine, I guess you could say, program that you could really try to model after. And that's what we're attempting to do, to educate more people out in the VA or elsewhere by coming. We also try to do some research. We also try to do educationals. We just do our best as we can. But it has definitely 25-year track record of excellent outcomes.
Thank you, Dr. Scott. I'm out of time. Ms. Brownlee?
Thank you, Mr. Chair, and thank you to all of you for your testimony. Dr. Gray, I wanted to ask you if you have any evidence at all that the story that you've told by trying to work through the system and do the right thing, if at the end of the day, do you know if there was any kind of investigation by the VA to determine both sides of the story in your situation?
No, ma'am. If I tell you the grounds for my dismissal were that I did not say good morning to a nurse. There was no addressing my issues. The Office of Inspector General, when I asked for a copy of the report as a result of my queries about physicians being bullied into overriding opioids, they found that the waiting times for physical therapy were not excessive. That had never been my complaint. That had nothing to do with prescribing opioids. So, no, to my knowledge, the issues were covered up, not addressed, and the entrapment issues that I alluded to were these trivial things that were used against me. They did not want to address the facts.
What happens in the VA when we know a patient is now an addict to their drug? I mean, I've heard over and over again today, it's just, different cocktails, more drugs. I mean, is there a point in which that stops and ceases?
No, ma'am.
Dr. Barrow-Rick, you said in your opening comments you had background in both acupuncture and physical therapy.
Yes, I'm glad you brought that up. I've been an acupuncturist for a little over 2 years, and every facility I've gone to, I've asked to be credentialed to do acupuncture, particularly for pain patients, and I've been denied. Not because I don't have credentials, I'm licensed as a physician acupuncturist, just because they don't want to open up a can of worms, because they're going to have to, patients are going to find out that the service is valuable, and then they'd have to pay for someone. Same thing with chiropractors. They don't have enough chiropractors. They don't do alternative things like massage or anything to that respect. Mr. Rentschler mentioned that when he went to physical therapy, they did nothing. Well, as a physical therapist, and after having been to 13 facilities, I can tell you that that is the absolute truth. Not only don't they do anything, patients can't get in.
Thank you, Dr. Scott. Do you use acupuncture at all or massage therapy in any of your?
Yeah, we credential people in acupuncture, and we also use massage. We also have a chiropractor. We also have alternative things, and I also submitted some new research on CAM stuff too. So we believe in that too, and we believe it. We use it as part of our overall holistic approach to pain management, and I think it's part of that whole looking at this thing in a more of a totalitarian thing than just a separate thing. So we do all those things, and if the physical therapy, if we cannot, we use a lot of. If there's sometimes if it's closer to home, we use non-VA care. I mean, we basically use what's best for the patient to try to be.
So, excuse me, you had mentioned about the training that you do. Do you train across the country in acupuncture so that others are licensed, or massage therapy, or
We currently, at the present time, don't have a manual or an, I guess you say, training program in those areas. We do have residency education, in residency programs like neurology and physical medicine rehab that we train individuals, or we could send them to places that get that training too. But we don't have train-the-trainers, if that's what you mean, at our
And is
place.
the training, it sounds to me the way you described it, the training is voluntary, that if people want to come and get trained, they come to your center, but there's not, you're not sort of overseeing centers across the country trying to look at, where they need to be trained, if people are up to speed and where they need to be.
Right. The 2009 pain directive says that every vision should have what they call a tertiary or interdisciplinary team for pain, and we're trying to offer our 25 years of experience to facilitate that in the vision area. But I don't have any. I'm just a local pain director. I don't have any kind of say on who comes and when they come, except they're always invited.
Thank you. I'm run out of time. I yield back.
Thank you, Ms. Brownlee. Dr. Wenstrup, you have 5 minutes.
Thank you, Mr. Chairman. My first question is, are providers at the VA protected in some way or free of some way from malpractice claims? Yes, doctor.
Interesting. In a way, yes, because basically you are suing the federal government. I'm glad you asked that. If I can go a little bit further.
Please.
All you need to practice at a VA is a state license. So if you have a Florida license, you can come to Virginia and work at the VA. I went to my state board of medicine to ask for help in this matter. The state of Virginia, as many of the states do, has an outstanding program where via internet you can find out in 30 seconds whether a patient has gone to multiple providers for opioids, whether they are double dipping inside the system and outside the system. The answer I got from my administrators was, for the federal government, we don't have to.
Yeah, in Ohio we have a similar program so that you can check what medications patients are getting and through multiple providers. And I've contended in my practice, which my last day in private practice was in December. And I always contended when I was dealing with non-providers or people outside of our office determining what patients should or shouldn't get, I would speak to them and say, well, how does this patient come to see you then if you're making this decision? And I usually would get what I wanted in that context, because I do believe that unless you sit down with a patient, you look them in the eye and you put your hands on them, you should not be making their medical decisions. But that's another issue for another day.
That's a real doctor, sir.
I'm sorry?
That's a real doctor.
Oh, well, thank you, ma'am. But my question really for all of you, what within the VA system would really motivate any of the providers or any administrator to be exceptional and to be efficient and to really provide a high level of care? What is built into the system that motivates that? Because for an independent practitioner in the private sector, it's your reputation, it's a standard of care, it's your state medical board. And I'm wondering what in the VA system provides that or motivates one, if anything.
That is private practice. I was a physician in private practice for 25 years before I went to the VA. And it is your pride. What you would have to do within the VA system, and again, this is my 2-year experience in one VA hospital, but you would have to interrupt the current system of reimbursement, let's say. Every one of my service chiefs, all of my superiors received a bonus, a raise, and a promotion.
On what matrix? Going up?
Correct. The theme here is do it as cheaply as possible, and this is my opinion, but do it as cheaply as possible. You well know these opioids cost pennies, just pennies, and I guess they think a human life is just pennies as well. I established a therapeutic swimming program at zero cost to the VA because the facilities were in place. The van, the driver, the pool. I had patients willing and eager to participate. I got no response from my supervisors. It was cheaper to just give them opioids.
If I, Congressman, that's a very good question, and I could answer it both from clinical side as well as a personal side. It's providing good quality care and having good outcomes. I find that's what drives it drives my staff to be very excellent, both in treating the war injured back, both treating this chronic pain program. I could sit down with any of my team, and they have great pride in what they do because the patients, they see the change, they see the improvement, they see the outcomes, and they're so overwhelming in this program that they basically they come to work loving the work, not for the pay but for the patients, to fulfill our VA mission here to serve those. And providing that high care and getting that atmosphere where everyone's important, everyone can contribute, everyone's suggestions are listened to and acted on. That's what makes a good quality. That's what makes the atmosphere a positive. That's what makes outcome. It isn't money. It's basically those, and that's what I found over time. That's why this program's going for 25 years. Because we've had people that constantly see these outcomes that are so good, and it keeps driving them to continue to be better and for the next patient. And just want to share that with you. And for myself, the same thing. What drives me is not what they can't do, what they can do. What drives me is just what some of the people said. When they feel helpless, hopeless, when they feel like basically pain is running their life, we get them control of their life. We get them control of their pain. And when they leave the program, I give them a new mission to go out and serve our country again. And basically, it's a good feeling. And then when they do that and they come back, it's priceless. It's why we're here.
I applaud you for promoting that type of motivation, and for those that provide care under your tutelage, that they're taking that approach. That's a personal pride, and that's how I practice. But I don't think that everyone has that luxury right now or performs in that manner, and I yield back.
Mr. Bilirakis?
Thank you, Mr. Chairman. I appreciate it, and I really appreciate you holding this hearing and allowing me to sit on the panel. Dr. Scott, I want to thank you for all the quality health care you've provided over the years. I represent, as you know, the Tampa Bay area, so I'm very familiar with Haley, and you, sir, are a true patriot. So thank you very much, and I appreciate your testimony as well. I understand from the testimony that approximately 30 teams from across the country have visited your facility to observe the model system and learn how to enhance pain treatment services at the facilities. Have these teams from VA, are the teams from VA or from the private sector? Are you aware of any programs similar to yours that have been established as a result of these visits? And what more can be done to increase the provision of programs like yours across the VA health system?
We've had 30 of them. They come and spend about 2.5 days, and they spend it first. We have groups. We have small groups. We teach them one-on-one. They have multiple disciplines, so we match them up with the different disciplines too. We show them the whole structure of the program. We show the administrative aspect of the program. We have a tremendous outcome-based type program. In other words, we don't measure pain with just a 0 to 10 level. We also measure all the different aspects of how you function with the pain. And so function is very important. So we have basically we developed our own scale there, to actually measure, pain, not just a number, but with how you interact with that pain, how you function with that pain, how you function with your wife, with your child, as it was mentioned. That's just as important too. And those things are all measurable, and we could then measure when they come, when they go, and when we leave, and we try to teach these teams that. And our goal is for them to go back and hopefully set up that tertiary, interdisciplinary team that could take patients in the more complex level and manage that too. And then we're available if they want to come back again, if they want to communicate by phone, if they want to interact too. So our goal is to really try to facilitate and help the VA learn what we've learned for 25 years.
Thank you. Thank you again for thinking outside the box. Of the veteran patients that received care through the chronic pain rehabilitation program last year, how many resided outside of your facility's catchment area? If you can answer that question first.
Yeah, probably more than half come from outside. We basically have in our mission stuff, we have a 100-mile radius. So if they're within 100 miles, they come in, we screen them in. If they're beyond 100 miles, like I mentioned, we've had them in Hawaii, we've had them everywhere in the country. We basically have to screen by phone, by mail, by letter, and that. And so we have different mechanisms, but it's usually about, if I admit four patients on a Monday and discharge 4. They're there 3 weeks. We have 12 patients there all the time. And generally, I'll have one from, let's say, North Dakota, Nebraska, and maybe even up in New England, and then one from local. So we see them from all over, and that's one of the neat things is that fact that they all, when they come together, they all band together like a band of brothers, and they support each other. And with that, then they leave and they continue on those relationships, and with those continued relationships, they keep the compliance and they keep adding to the program over time. So I think about it, Dr. Bilirakis, I think I should say Congressman Bilirakis, it's about half and half local, half distant.
How are we raising public awareness, so the veterans across the country can be aware of this great program?
Well, we try different things, and we're doing it, we tried it through the professional channels with education and with research. We tried it with website. Actually, we had our own website for a while. We tried it with on the internet system that we have in the VA. We're constantly trying to get the word out as best we can about this program. We are not completely up to full capacity all the time. We're about 85% bed capacity. It takes an individual, just so you know, because we monitor this stuff real closely, it takes us from the time of consult to time that comes in less than about 30 days. So so we want to make sure the access is there and maintained. We want to make sure the beds are occupied, and we want to make sure we're available to help any veteran in this country.
Well, thank you very much. Thank you very much, Mr. Chairman, for allowing me to sit on the panel. Appreciate it. Thank you all for your testimony.
Dr. Harris? Thank you very much, and I want to thank Dr. Gray and Dr. Pahorek for being here, because we do hear that it's a problem when you complain against a physician working in the VA system complaining about what's going on. And Dr. Pahorek, that you mentioned the Jackson facility. That is the one that was written up in the New York Times, a couple of prominent articles this year, right, about major problems with prescribing of controlled dangerous substances, and in some instances, particularly involving, as I think you indicate you were involved with, advanced practice nurses who prescribe and were not following DEA regulations. That is the same. That is the facility, right?
That's the same facility. Yes, it is.
That's what I thought. You also mentioned there was a facility. I guess I don't think it was that one. Must have been another one where one of the advanced practice nurses actually was indicated to be the chief of the director of pain medicine or the pain specialist in the facility.
Yes, a nurse practitioner is the director of pain medicine. Well, she's actually the director. I think there's a director on paper that's not there at the Wilmington VA Medical Center.
At Wilmington VA in Delaware.
Yes.
Okay. And do you know what that person's training is that would qualify that individual to be a pain specialist?
No, I don't, actually.
Okay.
But I can tell you it's not as much as a physician.
Okay, and that's what's going to bring me up, because there's this problem that's brewing in the VA about the nursing handbook that is going to say that all APRNs are supposed to become licensed independent practitioners. And that will basically certify that they can have independent practice of physicians. But your recommendations, number 10 and 12, are, number 10, reverse the trend to replace physicians with cheaper extended care providers. Is that what you're talking about, a trend somewhere to go to less expensive, because the VA does pay mid-level providers less expensive mid-level providers?
Yes, that's exactly what the trend is. And I feel that it's dangerous. I've been a number of places. I've seen problems with misdiagnoses. One of the things that really concerns me is these extended care providers were never intended to function independently. However, the VA has taken upon themselves to decide that they're equivalent in taking care of patients the same as a physician.
So that change to the nursing handbook would be of some concern.
Yes,
that would
exactly.
require,
It would be.
That's what I thought. And number 12, recommendation 12, is return specialty care to the domain of physician specialists. Now, this is intriguing to me because, as you know, advanced practice nurses claim specialty training that, and I know because I'm practicing one of those specialties, that is far less training than a physician gets. But according to the VA, under the new nursing handbook, my understanding is an advanced practice nurse claims specialty training and is certified usually by a nursing group in that specialty, then they would have independent practice in the VA to practice that specialty.
Yes, and that's what's happening. A lot of times when you send a patient to a specialist, you'll get most of the time you'll get a report back from a physician assistant or a nurse practitioner, and there may or may not be any supervision by the specialist.
Okay, that's what I thought. Thank you very much, and I'll yield back my time.
Ms. Brownlee has another question she'd like to ask.
I just wanted to ask Dr. Gray, perhaps, did you ever have an opportunity to refer one of your patients to this facility in Tampa?
Thank you for asking that. I brought that model, the Tampa model, back to Hampton and asked if we could implement it. As a result of the pain conference, which was held in Florida, and it was for VISNs 1 through 11. I was told we had no need of it. We had opioids. We certainly didn't need anything like that. And if you try and refer outside of your VISN, the answer is no. So for us in Virginia, we had Richmond, McGuire, where we could refer patients. And just as the gentleman referred to earlier, they can get an appointment. It'll be 12 months, 14 months, 16 months from the date that you call for the appointment. And that is deemed adequate.
Thank you.
Let me follow up that. Who told you that you couldn't refer or couldn't bring that model back?
The chief of medicine, the chief of primary care, the chief of staff.
Thank you. Well, I thank you all for being on this panel and for your testimony today. You all are excused, and we'll welcome the third panel to the table. Thank you.
Thank you.
Thank you.
Can I have this?
Joining us on the third panel today from the Department of VA is Dr. Robert Jesse, who is the Principal Deputy Undersecretary for Health for the Veterans Health Administration. Dr. Jesse is accompanied by Dr. Robert Kearns, the National Director for Pain Research for the Veterans Health Administration. I'd like to thank you both for being here today. You unfortunately have the job to explain what the VA is doing after we've had this testimony from the previous two panels, so I wish you luck with that. Dr. Jesse, please proceed with your testimony.
Thank you, Chairman Banashek and Ranking Member Brownlee and members of the committee. Before I start into formal remarks, I would just like to address Ms. McDonald, Ms. Green. I'm sorry, I can't turn around and still be on the mic, but there are no words that I can say to express how deeply I feel about the suffering your husbands were going through and the suffering that you are going through now. But I would like to thank you for coming forward and telling your story. And if there's any way that we can honor their life, it's by keeping that story out there and by ensuring, by you holding us to the fire, that we learn from it. Your comments about not letting this happen to other people are very, are taken, and I do so much appreciate your being here. And likewise, to Mr. Rentschler and Menard, thank God you're still with us. And whatever we can do to restore your trust in the VA, please give us a chance. So let me just start by extending those sympathies to all our nation's veterans who suffer from chronic pain and from the many devastating ways in which that presents. The VA, let me be very clear that we are strongly committed to ensure that veterans do have what they need to manage their pain, and that includes not just medications, but to truly get to the root cause of this. This is not an issue limited to veterans. Veterans are a population who are particularly challenged, but this is a national crisis. And in 2011, the Institute of Medicine published Relieving Pain in America. This challenges tens of millions of Americans, and it takes an incredible toll on morbidity, on mortality, on disability, and it just has an incredible impact on not just the people suffering pain, but their families and their communities. The burden on pain amongst veterans is considerable. I think it was mentioned up to 60%, certainly around 50% of the returning veterans from this were affected to some extent by chronic pain, and they often require intensive strategies, as you heard from Dr. Scott, for the effective management of that pain. Sometimes that requires the use of opioids. These are proven therapies, and particularly in severe pain, when other medications and modalities have not proven to be fully effective. To be very clear, we all know that there are risks to these medications. There are risks to patients. As you heard from Dr. Gray, there are risks to providers who at times provide these medicines, and we all know that there are risks to the communities as well. And VA is working broadly across all segments with partners to try and ensure the effective use of opioid therapy when indicated for patients with chronic pain. The VA has been at the forefront of health systems in this country in trying to deal with this issue. We began in 1998 with a national strategy for pain management. In 2000, the VA recognized pain as the fifth vital sign. This was, I think, an incredibly important statement requiring providers to routinely screen and assess for pain as a vital indicator of health status. A year or so later, the Joint Commission came up with a similar strategy. The Pain Management Directive, as you heard, was published in 2009, and that described a series of policies and procedures for the implementation of a step care model of pain that is the single standard of pain in the VA. VA has worked closely with DOD. In 2010, we published evidence-based guidelines, and we've continued that relationship through a number of strategies, including the Health Executive Committee chartering a joint pain work group, the singular goal of which is to ensure that the pain treatment strategies used in DOD are consistent with those used in VA, so as service members traverse from active duty into primary care, there isn't a disruption in their care, and you heard the devastating consequences of when that happens here today. Improving education and training on safe opioid therapy. This has an opioid safety initiative. This is actually finally giving us the kind of data that gives us the insight to see how these prescribing practices are occurring across the country. And when we have that data available to clinicians, we can see significant successes in the reduction in the use of chronic opioids. We also have public safety initiatives. As there was discussion earlier about participation in the state prescription monitoring programs. It was not that the VA was, we didn't have to do it, it's that we were not allowed to do it. In 2011, we asked Congress for legislation that would permit us, and its wisdom, Congress granted that legislative relief in 2012, and now VA is participating, or will be participating in these state reporting boards. It's very important for both the patient safety as well as the safety of communities. We have expertise in this field. You've heard from Dr. Scott. I'm here with Dr. Kearns, so I'm not going to go through all that right now. So I know that my time is up. I do want to acknowledge, Mr. Chairman, that we are committed to improving veterans' health and well-being. We know they have difficult problems. We know that they are suffering, and we are doing absolutely our best to try and change a system from one that rewards an encounter and gives a prescription to one that is built on healing relationships. This is crucial and vital to dealing with all of our patients, and we certainly thank the efforts of this committee and the full committee in meeting those goals. Thank you.
Thanks, Dr. Jesse. Yield myself 5 minutes to ask questions. I guess you had a standard, 5-minute talk there. I wish you would have responded a little bit to the testimony that we've had previously, because frankly, I feel bad for you because you have to come here and defend the VA and tell everyone how you're really working hard to fix the problem. But what I would like to know is, what are you going to do about the situation where Dr. Gray described, where she was told to do something and then she didn't do it, and then they changed the record? What's going to happen with that? I mean, apparently nothing happened. So are you going to take that and do something about it?
No, I first of all, I was not aware of that until today. VA actually.
You think that's a good idea?
No, it's absolutely not a good idea.
Well, are we going to do something about it?
Yes, I'll have to look into it. I don't know the situation. I've only heard this from Dr. Gray today.
Right. I mean,
but
me too.
As I said, for VA to change a record, there's actually a formal process that's required to do that.
You think a physician note should be changed? What are the circumstances that would allow an administrator to change the note of a doctor?
As far as I'm aware, there would be none unless there were factual, untrue, unfactual issues in there. In fact, we do change notes all the time.
I appreciate your comments, but what I would like, if you can maybe answer me this, could you please figure out the policy for that and maybe report back to me in maybe a month or so with this circumstance? Because I just don't think that that's very good policy, and I don't know if I think Dr. Gray's pretty disappointed about the way she was treated, and I mean, I can see that the VA has to prove it and all that, but I don't think that's sort of the behavior that we want to foster in the VA. So if you could you do that for me? Maybe
Absolutely.
Come back to the committee with a report?
Absolutely.
Okay, now let me go on from there. The policy of having a pain specialist appointed at a VA hospital who has no previous experience in pain treatment, do you think that's a good policy to have? Now, why was Dr. Gray appointed the pain specialist when she's no previous experience in pain? I mean, she's an internist and a rheumatologist, so I mean, she has some experience there, but why would somebody like that be, or a nurse practitioner, for example, be designated as the pain specialist? So why would that happen?
Well, I can't explain why it happened in
you think
Dr.
that's a
Gray's
good policy?
So I think there's.
I know you're in a tough situation here because you have to defend the VA, but you see what I'm trying to get to is that these policies are indefensible, and they should be changed. And you sitting there and saying, we got to do better. That's all well and good, but I'd like to see some actual plans to make that happen.
So we have pain medicine specialists. That's a specialty within medicine. It has separate boards. And to confuse the terms of pain specialist, pain points of contact, and pain medicine specialist, I think we need to be clear about the language. A small facility, a CBOC, is not going to have on staff a pain medicine specialist.
Well, no, of course. But, I mean, she apparently was more than just a pain point of contact. She was the pain specialist, according to what she says. She didn't describe herself as the pain point of contact. I mean, I'm a general surgeon, and I probably deal with a lot of pain, maybe not as much chronic pain as the average family practitioner, but, I usually have a system of where to refer. And so that one person is dealing with the pain treatment, and it's not just narcotics, it's a whole spectrum of care, such as Dr. Scott mentioned.
Well, one of the key principles of a step care plan, as is outlined in the directive, is actually knowing where and when to refer. That's why that system was set up, so people are not trying to manage things that outside their scope of capabilities.
Well, it sounds as if Dr. Gray and the other doctor were encouraged not to refer people, but encouraged to use narcotics, which, I don't know, you may...
Well, that's indefensible. That's absolutely indefensible, and as physicians, they should feel absolutely that they should refuse to do that. I have in my career in the VA, I have never been forced or asked.
I'm glad to hear you say that, Dr. Jesse, frankly. So thank you for saying that. And I would then say to all physicians who work in the VA to stick to your guns and treat the patient as you think best. And please report this kind of stuff to us here. I think I'm out of time. Thank you very much, Doctor.
May I follow that? Or...
See if Dr. or Ms. Brownlee wants you to do it.
Well, I'm sorry, but not on my time. Maybe on someone else's. So, Dr. Jesse, I just want to understand your responsibility in the VA. Is your responsibility for quality of care, or is your responsibility to oversee and make sure the system is working and that you're really accountable? In today's hearing, we're talking about pain management, that you are accountable for the VA and how they perform pain management?
So I don't think that's an either-or question. I think ultimately the accountability is that all veterans receive absolutely the best possible care they can receive.
Okay.
And that includes the ability to compare that care that they are receiving to some standard, if there is one, to certain expectations, and certainly to the expectations of the patient.
Well, I think in today's hearing, I leave compelled that the system appears to be broken. I'm going to have faith that there are pockets of excellence, and Tampa, it looks like there is one certainly there, and there probably are in other parts of the country. But how do you respond to the comments about we have a system of quick and cheap over good and thorough, and the basic principles of medicine have been abandoned? I mean,
I would argue, and I'm not one that would like to argue with other witnesses, but I don't believe that is the case system-wide. The question by Dr. Winstrup was asked, what would motivate somebody to work in the VA if it's just quick and simple? And the simple or the very complex answer is that we are there because we want to take good care of veterans. I had a choice in 2000 between going into private practice, actually going to work in industry, or working in the VA, and I chose to work in the VA. At that time, it was not an excellent system, but I wanted to make it so. Today, I think it is an excellent system. It's not outstanding. It still has problems, but we are making it better every day. And the fundamental reason behind that is because the veterans actually really appreciated what we did for them. And a certain person by the name of Harold Jesse, who I was born on a Navy base. I grew up with my father, who was a career naval officer. I entrusted his care to the VA, and I wanted to give back. And people work in the VA for those kinds of reasons, not because it's an easy come, easy go system.
And I'm not questioning your commitment to that whatsoever. I absolutely am not. But it's, how do we get your commitment permeated all the way down to each and every one of our veterans so that they are treated in the way that they need to be treated? And clearly, walking away from this hearing, I think we all have to agree that there are areas that we must look into, and there are areas that I think we just have to put on our chart, get to the bottom of it, and figure out ways in which we can improve upon it. And I wanted to also ask, Ms. Green in her testimony asked about what the VA does after a death of one of our soldiers, a veteran, and the analysis that is done thereafter. And so I wanted to follow up on that question to understand if that's happening after every death, and are we collecting data to determine the cause of death? And so are we collecting it and doing it?
So every unexpected death is supposed to be studied. This is how we learn. As physicians.
Well, wouldn't in a pain management situation, when there's not any, you're not having heart problems or other kinds of things, would that more or less qualify under
absolutely,
unusual?
because those are unexpected deaths, as are the suicides. And one of the things where we really are making a change is historically we've asked, did we do everything that we should have? And often the answer is yes. But the real question is, did we do everything that we could have? And that requires a much deeper introspective view into each one of these cases. And we are beginning to change the culture that we really begin to get to that level of understanding and depth, because that's where we're really going to be able to begin to change this equation.
Well, it is a cultural change, and that cultural changes are hard, really, really hard. But are you collecting that data?
So we have that data. We've in the past couple of years actually been collecting data in a way that it becomes searchable. So we can look at that. We also have the National Center for Patient Safety that does the root causes analysis, and they roll all of them up and look for commonalities across the across the systems where issues arise. And this is really key, because often seeing it once doesn't really raise a red flag, but when you can look across the system and see it happening 2 or 3 or 4 times, then it does. And then we really need to understand how the system is allowing these things to happen. But it's only when people look, it's only when people like Dr. Gray raise issues and can do that in a way that they feel safe. And I apologize that seemed to be contentious in her instance. But the ability for people to safely raise issues without being getting into trouble for it is the foundation of a just culture. And the only way that we're really going to change patient safety outcomes and improve healthcare.
Well, I would certainly be interested to see what the data is and what any conclusions, may come from it, because anyway, so we can have that conversation another time. Thank you for your
we'd be happy to
testimony.
do so.
And I yield back.
I appreciate your comments there, Dr. Jesse, and let me just say that I assume that Dr. Bahorik won't face any negative professional repercussions in the department as a result of her testimony here. Is that correct?
I would certainly hope not. And if she does, she should let me know.
All right, thank you. Mr. Wenstrup?
Thank you, Mr. Chairman. I want to applaud so many the caregivers in the VA system.
Thank you.
I know that in my private practice, 2 of my partners give a couple days a week to operate at the VA, and they only have the interest of the patient in mind, and that's why they're serving at the VA. And I think that's reflective of most at the VA. It's a system that I think we have to deal with and have to address. And, the purpose of these hearings is to hear the truth and to right wrongs. And hopefully we'll accomplish that with what we're doing here today. To Dr. Kearns, we hear the testimony today about the spinal cord stimulator, and I'm sure you're very familiar with that, with what you do, I would imagine. Would that be correct, sir?
First of all, yes. Let me echo the comments of others. I really don't want to miss the opportunity to express my sympathies to the people that were on the first panel in particular, and actually to the trouble that the physicians on the second panel have also experienced in the VA. So yes, I'm well aware of spinal cord stimulation. Just so you know, I'm a psychologist, not a physician, so I'm not a prescriber. But it is maybe to the point about spinal cord stimulation. It's an evidence-based therapy for certain, but not all chronic pain conditions, only actually a small proportion likely. It is a capacity that we're growing in VA. It's my understanding that as many as 40 of 152 core facilities actually do implant spinal cord stimulations, and a much larger proportion, certainly a majority, have pain medicine specialists who have the capacity to manage care for veterans who have received spinal cord stimulation either in the VA or outside the VA.
So, of course, you're concerned when you have the testimony earlier where go to the physician and he says, I'm not even familiar with the procedure. That's of concern. So from where you sit, do you feel that you have everything you need to make providers aware of all the modalities that are available, and that you have the providers that can actually provide that type of care?
So thank you for that question. I was also privileged to serve, actually, not as a representative of the VA, on the Institute of Medicine committee that this Congress chartered. This is a key problem in the United States and in the VA that we're, in fact, I think, represent a model of what we're trying to do in terms of improving education and actually training of providers in VA. So to one key, it's just one key example. I know there's interest of this subcommittee about the interface between VA and Department of Defense. So there is a Health Executive Committee chartered work group, and really from that has emerged actually a very well-funded joint incentive fund initiative that promotes education and training in consistency of pain care across the DoD VA. I'd also say there's a complementary initiative, well-funded, to bring auricular acupuncture, really that's been developed in the battlefield in DoD into the VA and build that capacity as well. So these education and training initiatives are very important and timely as we work to really address a national problem that most everybody from medical schools, nursing schools, other professional schools acknowledge as a failure to provide this education in our professional training schools. And I like the work that VA is doing in that regard.
Thank you, and I yield back.
Thanks, Dr. Wenstrup. Dr. Harris?
Thank you very much, and thank you, Mr. Chairman. And you know, as a veteran, I do know that and I appreciate that the VA system is trying to do its best in difficult environments, within budgetary constraints, within personnel constraints, et cetera. But I want to ask specifically, since one of the issues that came up since the hearing is on prescription narcotic overuse, perhaps, in the VA system. And, you know, one of the findings, that was at the Jackson investigation back earlier in this year, was this issue of, you know, advanced practice nurses, the supervision of advanced practice nurses, whether it was adequate. There were all kinds of, and you've read the report, you know what I'm talking about there. And now, you know, one issue that's come up is this nursing handbook issue, where instead of the VA kind of following along what Dr. Bohorik's recommendations are, which actually, you know, in an attempt to provide better treatment for our veterans, including those in the pain management system, is, you know, one of our recommendations, reverse the trend to replace physicians with cheaper extended care providers. But the nursing handbook change, which would encourage all advanced practice nurses to become licensed independent providers. For instance, let's say you had an advanced practice nurse who was named the pain specialist or medicine, whatever the title is at the VA, but that person felt uncomfortable doing that. They felt uncomfortable in independent practice. They actually thought that it was appropriate to be collaborating or supervised by a specialist physician. The nursing handbook says they have to go work somewhere else. You either achieve independent practice or you go work somewhere else. This is strange because in a environment like pain management, or in the environment on a care team, like in my specialty, anesthesiology, you know, the culture usually is that there is a culture of it's multidisciplinary, it's collaborative, and with recognition that there are different levels of providers with different levels of expertise. It seems to be going exactly the opposite way with that thing. So I'm going to ask you, Dr. Jesse, do you feel, given that this is under serious consideration, I know that the ranking member and chair have letters to you addressing concerns, and the AMVETS and other groups, do you feel that the training is equivalent, or the ability to treat patients is equivalent for the APRNs achieving licensed independent practice and medical specialists?
So,
simple question. Do you roughly make?
Oh, no, I don't equate them.
Equivalent?
No, but I want to be clear about something. The nursing handbook was a draft. It's not been approved.
So what I'm getting to is, what is your opinion on it, since you are going to be one of the decision makers, I understand.
So I'm a cardiologist. I don't believe that a nurse practitioner, I have very good nurse practitioners and PAs that work with us in cardiology, but we work as a team.
And
just like you work with the nurse anesthetist as a team.
Independent practice assumes not working as a team. That's why it's called independent practice. And in fact, under statute in states that establish independent practice, it specifically says, and I can quote from the statutes, that they work without involvement, do not requiring no physician involvement. That's what independent practice means in state statutes. No physician involvement. In the pain management program in the VA system, do you think that would be an improvement?
No, not necessarily.
Okay, not necessarily, but under what circumstances would that be an improvement?
So if we had a if we had a VA facility that did not have inpatient surgery, outpatient surgery, but there were the need for some level of skills that a nurse anesthetist could bring, that would be useful to veterans so that they wouldn't have to travel. Now, in our system,
I asked about pain management, not anesthesia. Specifically, I asked about pain management.
But in those situations, whatever the nurse anesthetist could bring to that, it would be useful to veterans. But they would still be working within the construct of a team, even if that team were connected to one of the major medical centers. So again, this handbook that you've seen is a very early draft. It is not agreed upon by the system. We will not move anything forward until we've had robust discussions with external stakeholders, including the societies. I know ASA is very interested in this. I know the family practice folks are very interested. AMA is very interested, and I can tell you that this will not move forward till we have had those discussions with all of the stakeholders.
Sure, and I appreciate that. And specifically with regards to pain management, you understand the complexity of the DEA regulations.
Oh, absolutely.
And supervision requirement.
Yes,
because of course you don't have the ability of preemption with DEA law. Thank you very much, Dr. Jesse, and thank you very much for holding the hearing. And I want to thank the committee for allowing me to participate.
Thanks, Dr. Harris. If there's no more further questions, I'd excuse the third panel. Let me just say this. I think Mrs. McDonald brought it up at the very beginning, is that this is not the end of it, because there's many things that we'll have to address here. Dr. Jesse, I look forward to working with you to answer some of the questions that were raised here and develop an overall plan within the VA to markedly improve the pain management system there. And I look forward to your reports, and hopefully we can just maybe get together for a couple meetings, outside the hearing venue.
We would very much like that, sir.
Make progress in this area. I want to thank again all the members of the panels that have participated here, and thank you so much. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, so ordered. I'd like to also thank all witnesses again for joining us. The hearing is now adjourned.